Right, we have a very full agenda, so we should get started. Thank everyone for coming. So first we have approval of the minutes for our November 1 meeting. Are there any additions or corrections?
I move today.
Okay, all in favor of approval? All right.
Yeah.
All right. Opposed? None? Okay. So just a bit of history. When I finally took a look and read the law, which I had agreed to chair this meeting and realized how complicated that law was, sat down with David, our esteemed executive director, who was responsible for some of this stuff. I said, "Oh my God, this is a pretty detailed law, and it requires a fair amount of in-depth understanding on the part of the commission and commission members." So we created the idea of having our subcommittees to sort of do a little more, not a little, but do in-depth and then bring those deliberations to the commission. And I hope all my fellow commissioners would agree that it's worked well. And so we've been very, very good. So, but we've now moved on, and there have been changes in what we do and what's going on. So I thought it was appropriate that we take a hard look at what we do and think about redesigning things. So I've asked David and more importantly Colleen, who is the real force here, if you haven't figured that one out, because I had to tell you, to take a look at the committee assignments. And so David and your executive director, you did, and then Colleen will take us through where you guys and what we came up with. Thank you.
Great. Thank you, commissioners, and thank you everyone for being here today. This is our last meeting of 2017, and we have a tremendously full agenda of work here today, touching on many of the core responsibilities of the Health Policy Commission. I want to start today by just making another public service announcement for open enrollment through our state's connector. Open enrollment is through the end of January. So encourage everyone in the audience and those watching online to promote the open enrollments. The holidays are a great time where you may be with family and friends who need access to great affordable health insurance, and the connector is the right place to go for the right plan. So public service advertisement on behalf of the connector. So we do have a full agenda today, and we've moved the executive directors up to the beginning of the meeting, and so I'm going to just move through this really quickly. But in light of our kind of 5-year anniversary and the end of the year, wanted to highlight some accomplishments of the HPC as we do by the numbers. We're always a data-driven organization, of course. So the slide here just reflects, this is the first 5 years of the HPC with some of our key headline findings. And these numbers really reflect the different roles of the HPC. As a convener that holds public meetings, as a partner that invests in and recognizes healthcare providers in the Commonwealth, as a watchdog that examines market changes and their potential impacts, and as a researcher and reporter. And you can see across these different numbers, we've had tremendous success across these different roles. Would note the 206 public meetings that we've held in the past 5 years works out to be an average of a little more than 3 public meetings a month, which is quite a pace for the commissioners and for all of you who engage in our work. Would also highlight here the the patient-centered medical home certification program, which was designed by this body, by the HPC, to recognize practices that are excelling in integrating behavioral health care into their primary care practices. And pleased to have over 120 practices participating in that program. And I think even more importantly, this has now become the model for a national recognition program that NCQA is rolling out across the country, really pulling from the work of this commission. Important number here, which we'll talk about a little bit later, is 3.55%, which is our average healthcare spending growth since 2012. 2 more slides here with some numbers. This is just specific to 2017 and would highlight, again, the engagement of the public and the work and mission of the Health Policy Commission, as well as this was the first year that we elected to review and to modify the healthcare cost growth benchmark and set a new, lower, more aggressive target for 2018 through a very public and transparent hearing process. And this year we also launched our ACO certification program, which we have over 17 applicants in the current review. And the final slide here on this Executive Director report is our by the numbers for the cost trends hearings, which you can see continue to have tremendous public interest with over 3,000 individuals participating in person and online. You can see on the online viewing we had people viewing from across the world, including people from Pakistan, Malaysia, and China who tuned into our Massachusetts cost trends hearings, as well as I think a lot of website traffic for people interested in the hearings, interested in the work that we had collected, accounting for more than 15% of all website traffic to mass.gov during those 2 days, which is quite remarkable when you think about the traffic that comes through the stage website. So with that is just a few highlighted numbers from our first 5 years and 2017. Want to switch now to the agenda item that the chair so artfully teed up for us here today, which is around a proposal to restructure our committees moving forward to better align, focus, and strengthen the work of this commission as we think about our challenges in 2018 and beyond. And it was really important for the chair, and I think for all of us who've been working through this process this year, that our new committee structure align with the strategic priorities of the Health Policy Commission. And so we'll show just a few slides that I've shown before to this board, but that highlight some of that strategic thinking in putting together the committee restructuring. So here on this slide, which is slide 11 in your packets, you can see kind of the goal of Chapter 224, which is really focused on healthcare cost reduction and meeting the healthcare cost growth benchmark. The HPC works to achieve this goal through 2 main policy priority outcomes, and we do this in close coordination and collaboration with so many different state agencies and entities across the Commonwealth. But really the 2 core functions here are around strengthening the performance of our healthcare market and the transparency of this market, as well as incentivizing a more efficient care delivery system and the financial incentives that underlie that care delivery system. And these 2 policy priorities can work together and reinforce one each other, again, with the goal of reducing healthcare costs and spending growth. This slide, which I've shown before, again, highlights some of the roles that the HPC plays in order to promote these different policy priorities, and I mentioned them before, so I won't read through these again. But this slide kind of puts this all together, and it starts, of course, with the board and the staff working together on these strategies for these policy priority outcomes, again, with the clear goal of reducing healthcare spending growth. And it is in line with this strategic framework that we are proposing a restructuring of our committees. And so with that, I will turn it over to the Deputy Executive Director, Colleen Elstenmeyer, who will talk a little bit about our history with the committees as well as what we're proposing based on Chair Altman's direction.
Great, thank you, David. So that transitions us perfectly into the new committee proposal that Chairman Altman asked that I walk through with you today. Currently, the board is divided into 5 committees. The original committees were established in late 2012, shortly after the establishment of the HPC, and began meeting in January 2013. They were really built around Chapter 224, the responsibilities within Chapter 224, and represented a growth phase of the agency at the time. So for the first 5 years, each commissioner sat on 2 committees, with a few commissioners having additional responsibilities of sitting on the Administration and Finance Committee, the A&F Committee. And this slide in front of you is just a by the numbers slide representing the incredible amount of work that these committees have overseen over the last 5 years. In fact, the committees have met 138 times over the past 5 years. That's in addition to the 56 board meetings that we've had, including today's meeting. So as you all well know, your appointments are volunteer appointments. So just wanted to take a moment to say that we really appreciate your commitment to the HPC and our mission, and just really illustrative in the transparency that we have with this public meeting process. So the original committee structure is really a harbinger of what we want to propose to you for this new dual committee structure. So the chairman is proposing 2 committees that really line up well with the strategic planning slides that David Seltz just presented. The first proposed committee tracks really closely to the former responsibilities of the CTMP and CHICI committees. You'll remember the Cost Trends and Market Performance Committee and the Community Healthcare Investment and Consumer Involvement Committees. These were led respectively by Commissioner Cutler and Commissioner Ward. I won't go through this slide in detail because it's right in front of you, but just to say some of the focus areas would include the benchmark establishment process, the performance evaluation process, post-transaction reviews, and market monitoring and oversight responsibilities. The second committee, this committee tracks really closely to the former responsibilities of the CDPST and KIP committees. We always use their acronyms, so I'm using them again here, but that's the Care Delivery and Payment System Transformation Committee that was led for 5 years by former Commissioner Carol Allen, and the Quality Improvement and Patient Protection Committee, which was originally led by Secretary Sutters and more recently by Commissioner Cohen. We are proposing, and the Chairman Altman has asked Commissioner Cohen to retain the chairmanship of this committee, and the previous committee that Commissioner Cutler retained the chairmanship of that committee as well. This committee would, some of the focus areas, again, not to walk through the whole slide, would oversee the care delivery certification programs, our legacy grant programs, as well as our new investment programs, and various research areas, including behavioral health integration, avoidable hospital utilization, and APM adoption. Finally, we just also note that the chairman's not proposing any changes to the Administration and Finance Committee that I mentioned at the top of the presentation. This committee, as you all know, meets a few times annually, reviews our annual operating budget, reviews our financial controls, and also evaluates and sets the compensation and salary for the executive director. So before turning it over to the chair, would just note that, as always, we encourage and welcome all commissioners at both committee meetings. We're hoping to set up the structure this year so the committees are actually back to back on the same day, which I know a lot of our public attendees will also enjoy that. And that, just also to note that all major decisions will be rolled up and taken up by the full board, of course. So turning it over to the chair, we request any feedback, any discussion amongst yourselves, or anything else that you guys would like to discuss. And finally, if there is consensus, we do have a vote available for you today if you want to lock in the new committee structure.
Okay, well, thank you, David and Colleen. Comments, questions, anybody? Everyone feel comfortable? By the way, Elizabeth, let me introduce you and welcome you to our activities. Elizabeth is works with the administration and finance, and will be joining us from time to time, and so welcome.
Thank you for having me here.
All right. So, any comments or questions that anybody wants to bring up? I just want to emphasize what Colleen said, that, we set these up with individuals, but for those of you who want to attend the meetings or join in any way to a committee that you're not on, you're more than welcome. As in the past, I will drop in where I can, and so I get an ex officio role on all the committees. That's why I'm so well paid. Not opposed to you guys who are. If not, I think we can. Yeah, we want to.
Just one question. Given that we're condensing the committees and obviously welcoming people to attend either one of these, would you send out the agendas to the full commission rather than just to the committee members? And then we'll know ahead of time if there's a particular topic that we're interested in on the alternate committee that we can plan to.
Yes.
And as you indicated, you will be sending out the schedule, the calendars for the 2018.
Yes, absolutely. Want to work with the new chairs to set up the committees and the agendas for the full year.
So on page 20 is the official motion that sets this up. Is there a motion to approve? All right, all in favor? Aye. Opposed? Abstentions? All right, thank you very much.
Thank you very
both,
much.
Particularly you, colleagues, for all the work you did in putting this together.
Thank you.
All right. Very good. David, you want to?
Great. So I think we're now ready to move into the business of today's agenda. Before we do that, I just want to preview and walk through some of the agenda items for the board and for the public. For the first hour or so, we're going to be doing a deep dive into performance results and lessons learned from Chart Phase 2. As you know, this 2-year, $60 million grant program is coming to a close, and we want to share with you and with the public some of the promising innovations and success stories from this work. Many of you commissioners were at last week's committee meeting where we had a presentation from our external evaluator, Boston University School of Public Health. They presented on some of their findings based on our evaluation that were really focused on the first year or so of performance of the CHART program, and were based on over 200 interviews of CHART frontline staff, CHART management, CHART CEO hospitals, and importantly, the community partners that the CHART hospitals were working with. The presentation that we're going to show you today is more up to date and more in real time in terms of some of the results that we've seen. And I know this has been a constant source of inquiry by commissioners is what is the sustainability for these programs moving forward? And so we'll have a particular focus on sustainability as CHART Phase 2 comes to a close, what we've heard from our CHART hospitals, and are very excited to have representatives of Addison Gilbert and Beverly Hospital here today who participated in the CHART program and will be able to present and talk through both their experience in the program, but also specifically around sustainability and how they're thinking about moving this program forward. Building off of the experience of CHART and our Healthcare Innovation Investment Program, we're going to be presenting a design for you today for the next round of investment, a $10 million opportunity that's really going to focus on reducing acute care hospital utilization, so think ED visits and readmissions, by supporting care delivery models that address the behavioral health and health-related social needs of complex patients. So we'll walk through that particular design. After that, we'll be switching gears to discuss findings from the cost trends report. The data and insights provided here today will give us identifying new trends and opportunities in our healthcare system, and would note that these are our select findings that will go into the full report, which will be issued in February 2018. So welcome, commissioners, your input and feedback and guidance to us as we prepare that final cost trend report. And then finally, we'll conclude today's public meeting with a discussion of material change notices, including a deeper discussion of one significant transaction that may warrant further review. Following this public agenda, it is anticipated that the HPC will vote to meet in executive session to discuss confidential matters regarding the HPC's responsibility to review entities referred to the HPC by CHIA and that have been identified as excessively contributing to healthcare cost growth and the potential for performance improvement plans. So at that point in the agenda, we will close the public meeting and will not convene again in a formal open public session. So with that, I'm going to ask my colleagues from the chart team to join me at the table here and walk us through the next big agenda item and encourage commissioners, of course, to pause and ask questions along the way with some of these results. So I think I'm turning it over directly to Margaret Sinise, who is our Deputy Director for Strategic Investment and has been with the HPC for over 4 years working on the CHART program specifically. So with that, I'll turn it over to Margaret.
Thank you. All right. In today's presentation, Kathleen Connolly and I will provide an overview of the CHART program. I will look back to refresh our memories about the challenges and opportunities that CHART was designed to address, and I'll provide some early results from the program, both across the cohort and for 2 hospitals in particular. Then I'll turn it over to Kathleen to discuss some themes emerging from CHART Phase 2, along with some early insight into HPC-funded CHART hospital strategic planning. And then, as David said, we'll welcome representatives from some of our CHART hospitals to speak about their program. The CHART investment program was created by Chapter 224 through a one-time assessment to fund nonprofit, non-teaching, low-price hospitals. CHART aims to improve community hospitals' ability to provide efficient, effective care, changing the way they deliver care to high-need populations. The HPC implemented a phased approach to investment, funding $9.2 million in early foundational activities in Phase 1 and $60 million in programs aiming to maximize appropriate hospital use, enhance behavioral health care, and improve quality and safety in Phase 2. Sadly, Phase 3 was not able to proceed as planned as the funds were needed to address last year's budget crisis. With few exceptions, the CHART hospitals have moved through the program as a cohort, building on their past successes and participating in HPC technical assistance activities as a group. Hospitals and health systems are facing unprecedented impetus to change the way they deliver care, adapting to meet the challenges of value-based payment. Community hospitals in particular are under pressure to change and are uniquely challenged by current market and utilization trends. The hospitals and HPC have together leveraged this substantial public investment to achieve shared delivery system transformation goals, addressing readiness to provide whole-person complex care. There is further a strong impetus to invest in care delivery redesign in the hospital setting specifically. Per capita hospital utilization is higher than the national average here in Massachusetts. Readmissions remain a policy priority. ED utilization is concentrated in multi-visit patients, and there are other examples. So CHART-funded programs that have broadened and expanded the role of community hospitals in addressing these issues. Further, we know that social factors influence health outcomes much more than health care does, and yet we spend far, far and away more on medical services than on activities that may address social determinants. We know that patients with frequent acute utilization have lower socioeconomic status on average. And so effective complex care programs must address health-related social needs in some way. And so it is in this environment, in this context, that the HPC invested $60 million in 25 programs over 2 years in CHART Phase 2. Phase 2 programs typically had a target population defined by frequent acute utilization at the hospital or by a behavioral health presentation identified using a clinical screen or using administrative data. Programs have two main aims, reducing inpatient utilization, typically measured by readmissions, or reducing ED utilization, typically measured by ED revisits. And now to some early results. Among these programs, a large proportion of teams are seeing some measurable results toward their aim, 83% at this point in time. And every single chart hospital has made advances in care delivery transformation as a result of their program, through their program, changing the way they deliver care in their communities. Regarding aim statement measurement, I do feel compelled to note that the data are preliminary as the program is underway, and so this number may change over time, and the data are self-reported. That said, we are seeing some truly impressive results, some of which we outline here. And potentially more importantly, we have seen very exciting transformation examples. At Addison Gilbert Hospital, the team established new relationships with community partners during the CHART program due to the needs the staff observed day to day among target population patients. For example, the team connected with Grace Center that offers shelter for homeless individuals, and they established a regular check-in with the center to take advantage of the resources. Hope I'm not giving you examples. At Hallmark, the COOP program and its ED care plans have catalyzed the hospital's broader adoption of ED care plans for non-CHART patients. So they piloted this among the CHART program, saw it was really working, and spread it elsewhere. The care plans concisely describe drivers of utilization, key contextual information, and important collaborators and resources in care. At Milton Hospital, hospital leadership held a full-day facilitated retreat with the CHART core team, a group of ED nurses, and key leaders where they reviewed existing protocols in order to improve and standardize care for patients with BH presentations in ED. And there are more examples not outlined on this slide. Holyoke Medical Center reduced use of patient restraints. Local skilled nursing facilities now regularly invite Winchester Hospital staff to attend their discharge planning meetings. Stigma toward patients with BH conditions is, as we know, unfortunately, a typical aspect of provider culture. And as programs progressed, multiple teams have observed changing attitudes among their ED staff. Teams developed policies to keep community health workers safe out in communities, out in patient homes, and there are more examples. So after providing an overview of some early program results at a high level, I'd now like to provide more detail on two examples. Harrington Memorial Hospital aimed to reduce ED revisits by increasing access to cross-continuum care for patients with a behavioral health diagnosis. As the Harrington team understands its own patient population, their patients' needs include the usual suspects of food, shelter, sleep, healthcare, long-term services, but also, and I'm quoting their program materials, their patients need hope. And so that's what the team seeks to deliver. Harrington conducts near universal BH screenings in the emergency department and inpatient settings, and patients are engaged by a multidisciplinary team, including social workers and navigators. Services include a substance use intensive outpatient program, a partial hospitalization program, and intensive follow-up out within the community. Harrington shows some really tremendous results to date, with a 34% reduction in the trend line of ED revisit counts to date. Notable success factors for this program include staff initiating and fostering relationships with community-based organizations, grocery stores and hotels, transportation companies, among others. This type of relationship management really takes time and effort, and they've invested that. They prioritize persistent and frequent engagement, face-to-face as often as possible. It's not a telephonic care management program. And the team together poured over the reporting, focusing on patients served, but also patients mixed. And so you can see the data analyst is squarely present on the org chart. That's an important factor for the team. And so moving to Mercy Medical Center, Mercy, in partnership with community-based behavioral health provider Behavioral Health Network, aimed to reduce ED revisits through improved services in its ED for patients with behavioral health presentations, including community-based warm handoffs to services and high-touch face-to-face and telephonic follow-up. They staffed the emergency department with BH-trained nurses 24 hours a day, 7 days a week, providing de-escalating interventions, care planning, and medication reconciliation. And so a BHN, Behavioral Health Network, community health worker was embedded in the ED to support patient transition out into the community, and a CHW team provided navigation and service linkage once outside. So Mercy has seen an impressive 21% reduction in the trend line in ED visits to date. As to success factors, at Mercy, care plans took on a whole person approach with a focus on mental, emotional, and social well-being in addition to medical factors. As with all teams, they measured the proportion of patients receiving contact from the care team within 48 hours of an ED visit, and Mercy did very well on this measure. Once they ramped up the workflow and the measurement, they averaged 82% follow-up within 48 hours of an emergency department encounter. It's really tremendous, notable, especially given the very large homeless population that frequents this ED.
Margaret, can I just ask you a question about those blocks under average volume,
Yes.
360 to 270? Could you just interpret them? Like, what is ED visits served versus the first block?
ED visits served a month reflects the number of patients who had an ED visit such that the patient received some service in the program. And so they are measuring visits rather than unique people because the patients keep returning, and so that's why it's measured in utilization instead of in people.
So, if there were 360 visits, 275 got services, is that what you're saying? And the rest didn't receive any services? I'm just trying to understand.
Sure, the rest may have left without being seen or may have, in some cases, declined specific services. It depends on the program. So, yes, that's what those numbers represent.
So, follow up, so it's not 350 individuals come into the ED in that month, of which only 275 receive the specialized services? Or is the 350? No, I get that, I find this also confusing. So the 350 visits, 350 visits for this service, or a screen for this service, of which only 79% actually accepted services?
So 350, there were 350 ED visits
For 170 patients.
for 170 patients that met the target population criteria for Mercy.
And 80% actually received service.
That's accurate. And with that, I'm happy to take more questions about my portion of the presentation, or else I'd be happy to turn it over to Kathleen Connolly to share some thematic findings.
So is it fair to say that, if I look at these two examples, of 170 patients a month, sorry. So the 170 patients a month at Mercy, they went to the ED twice a month?
Yes, that sounds right.
So you didn't actually decrease ED utilization, what you did was, this says reduced ED utilization. Did you actually reduce utilization, or did you actually increase community connection or service utilization?
The program results indicate that both happened. And so the average volume on the lower left of the graph is of the chart is really a gross count, and it doesn't indicate change over time. But the run chart that you can see indicates a 21% reduction decline in the count of revisits. And so both of these are true. Patients presented to the emergency department over time, less frequently returned within 30 days, as well as improve the community linkages as you described.
But on average, I'm looking at all of these, people still use the ED department at least twice a month.
Yes, that's right.
Okay, great. So we just talked about some very quantifiable results of reduction in acute care utilization. And so I wanted to expand a bit more on some of the care delivery transformation elements that really have taken place and taken hold in these CHART programs. CHART teams have transformed the work culture and the care delivery systems, moving from traditional care and a medical model to a more whole person centered care that leverages non-medical staff and community partnerships. And so again, we'd like to walk through some specific examples. So CHART teams really address the needs of whole populations in that it was all payer and it was all patients in the target population, not just trying to work with a subset of populations, patients in the target population. And teams went beyond working with patients when they were in the hospital. Post-discharge, teams were involved with these hospitals, with these patients, providing navigation services, advocacy, engaging in follow-up phone calls. And again, you'll hear more from our colleagues at Beverly who will talk about their program, but other hospitals like Bay State Wing, Mercy Medical Center, engaged in these follow-up visits and post-hospital contacts as well. Slide, please. The CHART teams, again, went outside of the walls of the hospital and the emergency department and really engaged with patients in the community. Most of the teams, and we'll show a slide later, used CHWs to do navigation, advocacy, and linkage to resources in the community to provide home visits and assistance with a variety of applications. They literally met patients where they lived, under bridges, the Dunkin' Donuts. Yes, Dr. Potter.
Can you just tell us on the personnel? Were these new personnel? Were these already in the hospital somewhere? How did they manage to staff?
New personnel. I mean, some hospitals had folks working in kind on the wards, and others staffed up and hired new positions.
So they were community health workers somewhere that were not working on this population. Just doing something
Yes.
else.
Yes.
And what was the training that was given to those folks to be trained as community health workers? Was that done through the grant? Was it done on site, or how? I was going to ask a similar question of who were these folks? Were they incumbent workers that moved up, but for the answer that they were new workers? Was there a training module that was given?
We didn't deploy a centralized training module. The hospitals who hired these CHWs undertook the appropriate training and onboarding as they determined for the needs of their population and their grant program. One of the, I think, lessons that we want to deliver from the CHART program is sharing the information about the spectrum of community health workers, their roles, their job descriptions. Obviously there's other agencies that work with community health workers, the Department of Public Health, and so our ability to align and share our lessons learned with them as they grow the professional state of this group of workers is going to be really key.
We have a slide coming up that details there are approximately 250 full-time employees that were supported through CHART Phase 2. And we'll describe a little bit about who they were and what types of roles they filled. We'll preview social workers and community health workers were the two biggest categories of staff supported through this program.
I was wondering if you could shed more light on the following. We discussed it last week, but it would be helpful if we could get more information. We have 83% of grantees that have seen achievable results. And the key question I have, that's really positive. How do we know what percentage of these organizations are going to continue with the program? And do we know what the criteria is that they're going to look at in order to determine whether they will continue? I think that's really important for us to look at.
So happy to report we have a lot of information about that in this presentation, and really pleased to have one CHART hospital here too, which is that they're actually going to walk through what their decision-making process was as CHART Phase 2 came to an end, what considerations they thought about continuing the program, both pros and cons, and a little bit about their decision-making. So that will be perfectly informative. Thank you.
And to your point, Commissioner Foley, while we didn't roll out a cohort-wide training program for any level of staff, within the grant, many hospitals wanted to segregate funding to do training of staff. And so many did training for CHWs around patient engagement and motivational interviewing. And so, for example, Lowell Hospital did a lot of work with their CHWs around motivational interviewing so that they could deploy those folks, and when they're meeting with patients out in the community, really try to set up relationships and then explore the reasons for the acute care utilization and attempt to really understand the root causes and then help meet those needs that are identified.
Next slide, please.
And so we often talk about, healthcare being siloed, and I would say our CHART programs really worked to break down the silos both within their institutions, and again, a theme that you'll hear me repeat and is stepping outside the walls of their institutions. So community partnership and engagement was very important in the CHART program and continues to be a cornerstone of the work that these hospitals are doing. For example, Hallmark Health conducted a needs assessment, a resource assessment to really understand what was already existing in their community so that as they deployed their CHART teams out to folks, they could then link up with the appropriate community resources. We had teams out at Marlborough that worked closely with the Department of Mental Health, program at Emerson, and the program at Milford established collaborative relationships with SNFs where they'd have regular meetings and they could do some case planning. And then you've heard about the Milton program really took up the mantle of interdisciplinary teamwork and had data analysts, social work, behavioral health navigators kind of coming together looking at what are the issues and how can they better address patients' needs. And we also, within the CHART program, we had money set aside for enabling technology. And this was really key to many teams to do real-time patient identification. Folks use the dollars in the CHART program to put flags in their systems so that when patients in the target population either presented in the emergency room or on an inpatient unit, they could be met face-to-face by a member of the CHART team to begin engagement and services.
We should, this is really extremely helpful. And as I think about both around the Commonwealth, but even around the country, what we're learning about what hospitals do, what they could do, and more importantly, what they should do, is really helpful. And it's important that we figure out a way to get this out in a way that others around the country and around the state can benefit over time. So let's, work on some kind of a national.
We're excited to talk a little bit about some of our preliminary ideas later in this presentation, and also want to come back to the board in early 2018 to talk about our broader learning and dissemination strategy. Because to your point, let's not keep this to ourselves.
That's right. This is a unique activity that I've seen. I don't know about others in terms of what's going on in the U.S. So it's great.
In addition to addressing the myriad behavioral health and social determinants of health needs of our patients, many of our CHART teams were on the forefront of working with patients related to opioid use disorder. And so just wanted to highlight a few programs across the Commonwealth that really tried to deploy interventions at the individual, facility, and community level to help patients and families dealing with opioid use disorder. Our program out in Berkshire set up a Suboxone Bridge clinic so that patients could get access to needed medication assistance therapy before they actually had an appointment with a provider or prescriber to kind of help maintain them during that time. Beth Israel Deaconess Plymouth CHART program really set up addiction assessment in the ED, linkages to detox, outpatient pharmacology, and then referrals to primary care, as well as doing work with the drug court. Hallmark Health System focused largely on patients with high utilization in the emergency department, but also to present at an Intermountain Health event next year. And so now to the question of strategic planning and sustainability. sustainability. So as part of our CHART grant program, and I wasn't here for it, so I can't take credit for it, but there was a foresight to ensure that there was funding for these programs within the grant to, as the programs came to an end, to think about sustainability. And so each CHART award had up to $50,000 available to engage in what we call strategic planning, but really we should think about it more as that sustainability planning. And so what CHART teams did is they got a variety of stakeholders involved, leadership, frontline staff, project managers, patients and families, to really look at the CHART program. They used a data-informed approach as well as interviews and assessments and feedback from other stakeholders within the hospital and the community. And then they really took a hard look at what worked well, what didn't work well, what should they sustain. And finally, they considered how they would sustain it. Many teams leveraged their insights to inform their Mass Health ACO planning process, as well as to tap into existing population health management strategies that were about to or were being put into place within their organizations. And so on the next slide, we just wanted to reflect the fact that after this process, all CHART hospitals intend to sustain some or all of their programs in a variety of ways. Clearly, the full CHART funded program of millions of dollars is not going to be adopted into any of these institutions, nor should it be. A lot of the funding of CHART was infrastructure learning and capacity building that then really allows folks to understand what's the right compendium of services and providers to meet the needs of their patients. And so, we have examples from spreading the learnings of CHART to inform population health management and the Mass Health ACO strategy, all the way up to fully replicating the CHART program in other parts of the institution. So, an example of expanding one hospital is taking a new manager of the ED case management position, and that's going to be funded to implement the effective components of the CHART program. And another, as you know, these CHART programs were hospital-based. One institution said they're going to move the CHART program and extend it to the primary care physicians in their service area. And then another let us know that they'll replicate the model of their CHART program for their Mass Health ACO program. So that's just a sample of some of the things that folks are doing. You look like...
I have a question.
Sure.
This seems contrary to what we heard last week, where the folks from BU questioned whether a lot of these institutions would continue because of cost factors and other factors as well.
So what's
Yeah.
what's the disconnect?
Yeah.
Yeah, so the BU folks had based their interim report, which they delivered to us recently, and you were at that committee meeting, Commissioner, and that was based upon interviews that had happened about a year and a half ago. So at that time, they were, most of these hospitals are about a year into their model. They're still trying to understand what's working, what's not working, and weren't really sure about the sustainability model. So now a year later, we have more real-time information. The teams, many of these hospitals have engaged in a Mass Health ACO program, and many are thinking about what has worked and what can be sustained going forward. So a bit of a time lag, I would say. Yeah. Yeah, I mean, that was right. That was at a point in time, which seems appropriate given that these programs were about a year into it. Hard for them to know, but we feel like we have a better handle on where things are landing now.
Kathleen, the information you presented is great, and it clearly shows improvements in quality of care. I'm wondering if there's any data on the cost of the care.
Yeah, I mean, we've talked about what type of analysis we can do. Obviously, we've used. We could model out reduced utilization to project costs, but we don't have a clean metric across the cohort to say X.
That was sort of my follow-up. That was my follow-up, which is we've invested $69.2 million in this program, and so what's the cost-benefit analysis? The quality appears to be clear. I mean, we got a little lost on the ED numbers over in this corner. Maybe it was us. But it would seem to me, since the Health Policy Commission is balancing cost and quality, if we're investing $69.2 million, we need to be able to make some statements about the cost benefit.
So last week, the BU team said they were going to be putting together a quantitative analysis. I presume what it's going to do is to take those charts, the run charts, I think is what they're called, and to attach dollars to those and then estimate the benefits. I encourage them to do the benefits both for the organizations that are involved as well as for the Commonwealth as a whole, because it may be that some of the savings accrue to the Commonwealth and not to the organization, or vice versa. So I think we were promised that we would have something like that.
Yes, that is absolutely the core function of our external evaluation. It is a mixed methods approach where we are conducting a lot of interviews and trying to get an understanding qualitatively of the impact of the program, both from patients, community partners, and frontline workers. But a big component of that, which was not presented last week, is the quantitative analysis of where we saw these utilization trends. What does that all kind of add up to? And I know actually there's a slide in an upcoming presentation from Addison Gilbert, who did look at this and try to quantify and think about what are the potential savings here. As with all of these programs, and I think with the healthcare system in general, with these utilization reductions, there's still some question of to whom do the savings accrue? Do they accrue to the health plan? Do they accrue to the hospital or the institution? Given kind of many of these hospitals still on a fee-for-service basis, it's a question about whether they were able to see this in terms of revenue savings to them, but certainly reducing healthcare costs is a core function of our work here.
I would also be curious, looking at, slide 48, so I'm jumping ahead a little bit, of clearly the district funding, which is part of the ACO Mass Health Program, clearly has become a revenue source, which is part of that lag that the Commissioner was speaking about. I'd be curious what the plans are for the hospitals who are not chart hospitals, or not part of the Mass Health ACO, what their sustainability is. I think we'd see a difference here.
Yeah, I was going to pick up on that too. I was similar, thinking about this like we have post-transaction reviews about what was said they were going to be able to do to maintain and come back and have a review of that. It seems we should do the same here, is that are we continuing to see sustaining the program both financially but also outcome-based, or have a review process where the program ends, what has the outcomes been since the program ends to 100% want to continue this. Should we see the same results? Should it be less? Should it be better? And having a post-review of that after the funding ends.
And that, thank you, Commissioner, and that is truly the work of really kind of the next year of this program. Even as these programs are coming to an end, we're going to be continuing to receive reports and data and information as we close out these. And really, our goal is to, once we have all the final adjudicated numbers, to be able to continue to process that, analyze it, look and post-review, and then even, as we'll hear, some programs are intending to sustain these programs moving forward, but that may only be for the next calendar year, and so there may be an opportunity even a little bit further out to see how much of these programs continue to be invested in and supported by the institutions.
I just want to emphasize both what you said and David and the Secretary. Obviously, we do need to do a really careful cost-benefit analysis, but we ought to be very careful about how we measure the benefits in terms of the total health. And as you pointed out, David, we need to look at if there are savings. It may not always attribute back to the institution, but may be attribute back either to the plans or to the government or something like that. So we need to be careful in doing that. On the other hand, we need to have a solid basis rather than wishful thinking. I agree with that. The other thing is, I mentioned at the subcommittee, I think we need to be careful about how we talk about failure or success. And it may turn out that a program is not continued at a particular institution, but not because it was a failure, but because in fact other things happened, like we did away with a more capitated or global payment system and reverted back to fee-for-service. and therefore they didn't get paid. On the other hand, when we look at institutions who said, well, we would have liked to continue this, but we didn't get paid for it, and said, well, you know, there are other expenditures that you're generating in your hospital that you're not getting paid for, and this one at least generated savings in some other aspects. Why are you continuing those? Because part of the issue is, you know, let's face it, in every organization there are power structures, and this is the new kid on the block, and often the ones who've been there want to protect themselves. So, you know, this is a really helpful, but it gives us an opportunity to step back and do a serious analysis, and I think the comments you heard from the commissioners, plus your own, are really very helpful.
Thank you, Commissioner. I just wanted to quickly, before we introduce our guests, just say thank you to all of the CHART programs. I mean, the privilege that we had to work and continue to work with these teams. As I alluded to, you know, as these programs wrap up, we want to stay engaged with these community hospitals. They have so much to teach, and we want to be that partner and that convener to bring others together and to share the lessons learned and the actionable next steps. So just want to take a moment to say thank you to our CHART teams. So with that, I would like to welcome our guests. We will be joined by Sandy Akers and Cynthia Cafasso Donaldson. Ms. Akers is a clinical administrator, RN, MSN, at the HRIT team for Addison Gilbert and Beverly Hospital. Ms. Cafasso Donaldson is a vice president at Addison Gilbert Hospital and Leahy Outpatient Center in Danvers. And they're going to share insights and lessons learned from the implementation of their CHART 2 program, which focused on reducing readmissions for high utilizing patients. Thank you.
Thank you, Kathleen. I'm Cindy Cafasso Donaldson. I'm Vice President for Addison Gilbert Hospital and for Leahy Outpatient Center, Danvers. We are members of Leahy Health. Today we would like to cover the background of our CHART 2 programs, both at Addison Gilbert and Beverly Hospitals, a little bit about our strategic planning process, and our future direction and sustainability. We'd also like to thank you for the privilege of allowing us to participate in both CHART 1 and CHART 2, and for being here today to allow us to share some of our work with you. The objectives of our CHART 2 teams were to prepare, the objective of the CHART 2 program, as you know, is to prepare community hospitals for operating in new payment models, value-based payment, population health management. The aim of our programs at Addison Gilbert and Beverly Hospitals were to reduce returns, so any bed, observation, or inpatient, by 20%, and to reduce emergency department returns by 10%. I'd like to introduce Sandy Akers at this point.
Hello, thank you very much for the opportunity to present today, and I've had the privilege to lead this team over the past year. At Addison Gilbert, we, for the system, we had a data analyst person who assisted with our analyst. At Addison Gilbert, we had 2.75 FTEs, a nurse practitioner, a pharmacist, and a social worker. And at Beverly Hospital, we had 2 RNs, 2 pharmacists, and 2 social workers. The target population that we served at both Addison Gilbert and Beverly Hospital were high utilizers that had 4 or more inpatient stays in a year, patients that were readmitted within the past 30 days, and then the socially complex patients, and those included patients with a substance use disorder, Medicare under 65, usually a disabled client, Medicaid population, and the homeless population. The target population we selected because their readmission rate was 3 times higher than the hospital average when we began. Totally enrolled discharges to date, that's total served patients, at Addison Gilbert was 1,574, at Beverly was 6,140. The target population accounted for about 33% of the total hospital discharges. So it's not just a small pilot program, it's a substantial program that we're running. Enrolled at any one time at Addison Gilbert is approximately 90 patients, and at Beverly, approximately 380 patients. And this is the target patients by payer. There was some discussion about who saves the money. This kind of gives a little bit of a flavor for that in the future slides that Cindy will go over. We have about 60 to 61% that is Medicare, 21 to 25% that is Medicaid, and 15 to 18% that is commercial payer. And those are the target populations by payer. So a total of 82 to 85% of the target population has a public payer.
So as we went into our strategic planning process, our goal was to objectively evaluate the Chart 2 program and provide recommendations for sustainability. We selected a task force of people within our organizations and outside of our organizations who controlled the resources, really. We also did a lot of data collection, both with focus groups. We hired an independent facilitator. We conducted focus groups who talked with our colleagues within the hospital. They talked with stakeholders within the community. They spoke with the HRIT staff within our hospitals and also with our patients. The data analysis was both quantitative and qualitative. We looked during our strategic planning process at budget review. We looked at return on investment in sustainability. We looked in detail at sustainability options, and we'll talk about that in a little while. We did numerous presentations. Communication was really one of the keystones of the success of our strategic planning process. So we went to our hospital board, the quality committee of the board, the Leahy readmission SWAT team to reach out into our larger system. Our CEO was kept informed throughout this entire process, and senior leadership was very involved in the process. We had wonderful guidance from Dr. Amy Boutwell and from Taylor Rolfing from the CHART teams and the entire CHART teams in the Commonwealth. So our strategic task force included Sandy and me, as well as the chief financial officer, the chief operating officer, the chief medical officer for the hospitals. We reached out into our Leahy Health ACO and brought in the president of the ACO. And we also kept our performance improvement director on the team because she was critical to our ability to analyze our data.
So the qualitative data analysis, our really purpose was to hear the voices of the stakeholders being the patients, members of the CHART team, colleagues that we interacted with, community-based people. We conducted 8 focus groups, 4 at Addison Gilbert, 4 at Beverly. We had over 50 attendees. We had an independent facilitator that facilitated the focus groups. We used standardized questions and a standardized process to conduct the focus groups. What we realized is we asked the questions, what interventions from the team and what roles were most effective. We wanted to know what should we sustain. So we were trying to get at what was the most important role and the most important interventions. The patient responded that the home visits were critical, the 48-hour calls were critical. They repeatedly expressed the persistence of the team and their outreach was critical, as well as to the patients. The social workers were the face of the grant. The social workers were the people that the patients interacted with on the most, even though there might be other team members behind that did visits, they related to the fact that the social worker was the face of the team. The colleagues and providers, they spoke about the value of improved med reconciliation, improved coordination of care. They repeatedly talked about it increased their job satisfaction From a colleague perspective, they had somebody that they could pick up the phone and call when they were in trouble with a behavioral client. They knew that they could call the high-risk intervention team, and that was of high value to them. Improved collaboration with community partners was also seen as a benefit and value to the team. By far, I think what we heard the most was, and the most powerful was the patient focus groups we did. And my one regret is that I didn't record the patient focus groups during this process, because the power of the individual patients that came to these meetings were remarkable. We changed people's lives, and they told us that. They absolutely told us that there were instances without a social worker going into the home, I wouldn't be alive today. Those statements were made on a couple of occasions. There was a father that came to our focus group that talked about the social worker that advocated over an entire weekend to get his daughter into treatment, and his daughter was still sober today. It was those types of testimonies that really nailed home the importance of the team to the patient. So just focus groups, I wish we recorded them. On the quantitative data side, we had some substantial results in reduction in enrolled admissions and utilization. The quantitative data demonstrated measurable improvements in readmissions, particularly for our enrolled patient population, and those are the patients that the team actually interacted with and touched. There was a 29% linear reduction in Beverly admissions for the enrolled population, a 33% linear rate reduction in Addison Gilbert Hospital for the enrolled population, a 29% reduction in readmissions from SNFs at Addison Gilbert, 9% reduction in readmission from SNFs at Beverly, a 24% reduction in Medicaid readmissions for Addison Gilbert and Beverly hospitals combined. And the next few graphs graph these results. Again, really remarkable for us was the decrease in the readmission rate, which was a 29% reduction for the enrolled patient population. Those are, again, the patients that we interacted with and touched. At Addison Gilbert, it was a 33% reduction for the enrolled rate, for the readmission rate for the patients that we served and actually interacted with. This is a combined chart for Medicaid readmission rate for Beverly and Addison, and it was a 24% reduction for the both hospitals in Medicaid. We actually combined this graph because the Addison Gilbert numbers were lower. We actually also drew a green line down the end of the graph just to show you impact of the team. In the summertime, we lost 3 social workers all at once, and we're now in the process of restaffing those social workers, and we immediately noticed the impact of the loss of the social work staff and what it did to the number of our readmissions. So we just thought we would highlight that the team, the importance of the team. The Addison Gilbert readmission rate for patient disposition, this shows the 37% from time period January to September of 2016 to January to September of 2017. Again, the highlighted arrow is our SNF reduction. Here we did have home health did not go down, and we actually looked at that and why didn't that go down. And if you look at the next slide, you see it actually did go down at Beverly. And we traced that back to the home health affiliate that we utilize at Beverly was different than Addison. And they were affiliated with the system, and for some reason they were more interactive with our goals, and they actually understood that we were trying to decrease readmissions, where in Addison they were self-selecting some of their own home health agency people, and they weren't necessarily as tied into what some of our goals were. We saw that difference. Again, we had a decrease of 9% for the SNFs as well, for the Beverly.
So we tried to get to return on investment, and we made some assumptions here. We started out with the actual readmissions for those patients with the blue line, those who were touched by the CHART grant. So those are actual readmissions at Beverly Hospital, because the Addison Gilbert numbers are too small to look into, for the time period January through September 2017. We then went back to before the CHART grant at Beverly Hospital and took patients who would have met the criteria. We took the same cohort of patients and we looked at that readmission rate and applied it here. This is definitely making some assumptions that that readmission rate would continue, that they are equal cohorts, but we felt that this was at least worth showing to you. This would demonstrate that if we use an expense of $10,000 per readmission, and again, that is an assumption, this demonstrates a reduction of 11 readmissions per month. And using those assumptions, it looks like that there is some return on investment. And if we go back to this slide with the share of insurers, it would look like 82 to 85% of the payer would be public payer, and so it would be the public payers who would be benefiting from this. And I'd be happy to flip back if anyone wants to see that.
So is that a net or a gross, or does that include how much you spent, or is it just the 1.3 million?
This does not include how much the CHART teams cost.
Yeah.
This does not include that expense. This would be,
would that be hard to do, to figure out how much it costs?
no, Beverly costs $2.5 million over 2 years, so it would be.
But it's not all the program costs were in this part of the program. So if you can try to attribute how much you spend from that on this, so you get a better sense of what was asked before.
Yeah, so this is a little over half a year, and so for four half years, Beverly was 2.5, so about 600,000. So it seems to have given a reasonable return on investment.
Have you looked at the impact on financials?
We have looked at the impact on total readmissions at Beverly and Addison Gilbert hospitals, and they have decreased. Financially, as you know, we are in a mixed reimbursement model, so we as a hospital really don't see the impact as clearly as this graph demonstrates. It's shared. The impact is shared with the impact is primarily with the payers, I would say at this point.
Okay, so we then looked at what worked, and clearly the team is critical to achieving success. Each member of the team potentiates the other members of the team, and it took almost a year to build an effective team. Out of the gate, it was not the right members in the right place. It took a year, a solid year, to build a team. Guidance and support from the Health Policy Commission definitely was invaluable. The monthly sessions with Dr. Bartwell were absolutely invaluable. We learned a lot from those sessions. We asked her several times, show us how to demonstrate return on investment, and how do we do that with the different payer models. She was very helpful in helping us with different high utilizers to drill down as to why the high utilizers and what we could do to intervene. Clearly, great value there. The high-risk team is now a visible part of the hospital and community. Now the emergency department will ask for the high-risk team members. Social services and case management looks for the team members, as does pharmacy, the SNFs, and the ACOs. We're definitely visible within the hospital community. Hallmarks of success also, I would say, will be the home visits, 48-hour calls, SNF rounding, and emergency department action plans. With regards to the emergency department action plans, we built into the EPIC system for high utilizers so that when the patient comes to the emergency department, There's a banner that flies across the screen that tells the hospital, the emergency room doc, that this is a high utilizer, that he can click on the action plan and see past history and who to call and how to prevent possibly an admission. We also had a lot of focus on our SNF readmissions. We do SNF rounding with discharge, with the RN on the team attending discharge planning process, which resulted again in significant reductions in readmissions. We've also seen an increase in redirecting admissions back to the SNFs from the ED rather than have them go into the hospital, and we've been working on that, and that's been successful as well. Again, effectively engaging the target population. I would say a model of the team was don't give up no matter what. You know, a lot of times people would come to me and say, can we discharge the patient? And I'd say, no, we're not discharging the patient. We go back at it and we try it again. And a lot of times it takes repeated contact and persistence, and be flexible and meet them where they're at. Need passionate clinicians who care about the patient. The team matters. Individual clinicians matter. Use data to drive performance improvement and critically analyze the data. We wouldn't have known we had problems with SNF readmissions if we didn't drill down by disposition where they were coming from. So the data actually drove the improvements. Clinical case review for detailed analysis of why high utilization. The lessons we learned were every week we sat down and we reviewed every single patient, and we went over the patient with the team, and we said, okay, why are they coming back, what's going on, and it was a detailed analysis of why are they coming to the ED, why are they being readmitted. We developed active collaboration with the emergency department, and again, the use of the ED action plans was really successful for us. We meet every other week with the director of the ED and our physician advisor with an ED RN that's on our team, and we develop more care plans accordingly. The loop map back notification, which is our database that we use for enrolled patients. The team knows when the patient's in the emergency department to respond down to the emergency department. Again, we talked about the ED action plans and again, ED diversion back to the SNF works.
So just briefly, our sustainability options are listed here. We thought in order to keep our strategic planning task force on task, we needed to put something in front of them. So the options that as Sandy developed this actually, we looked at what we considered every viable option. The first option was dissolve the teams, would not cost the hospital anything. We immediately discarded that option. We felt it was irresponsible to the Commonwealth after the investment they had made in us. We also felt it was irresponsible to our communities. We are a charity, we're here to serve our communities, and it was just not the right thing to do. So other options that we looked at were to share the teams with some of our partners, for instance the ACO, and share the expense of that team. It, however, pulled parts of the team away from the hospital base that we had so successfully built. Another option was to completely move the teams to the ACO and have the ACOs take over the expense of those teams. We ended up with option B, as you can see in the pink, which is that we are taking our teams, we're focusing around a little bit of a winnowed down model. I'll go to the next slide and get this all in one breath. We've winnowed the model down. We're focusing on social work. We're looking at behavioral health and substance use disorder services. We now have medication-assisted treatment available at Addison Gilbert Hospital and at the Danvers facility. So we will be moving forward to integrate that further into our inpatient services. Our teams will focus on that plus social work. Along with pharmacy, we heard strongly from our colleagues within the hospitals that they felt that the pharmacy contribution to patient safety was critical. And we'll use our RN or NP as a consultant for both ED action plans and for clinical case review. We hope to be able to apply for future HPC grant monies if those are available. And we'll be transitioning our community health workers to the Leahy Behavioral Health ACO program. So again, we thank you very much for your support and for all of the opportunity that you've given us and the patience you've shown as we evolved through this process.
I have just a really small question. If you flip back to slides 62 and 63, and maybe we can, great, thanks. You talked about on 62 why you believed you'd seen an increase year pre and post on home health. It's interesting that there was no real change on patients who were readmitted from home. Am I reading that correctly?
You are.
I wonder if you could just speak to that, because you did get good outcomes on the SNPs, but it would seem to me, and I'm not sure kind of how large that population was, but it would seem to me that's where you really want to make some change.
We actually prioritize looking at the populations of SNF and the home health more than we did the home. And actually the home was usually the 48-hour call was what we did to the home clients. And if they were doing okay, we would move on and focus on the other patient population. So we didn't really delve down into the home, and that's why I think we did not see as much of a decline.
The other two populations were where we had the highest readmission rates. So we did focus on those areas with the biggest issues.
Other comments or questions? Well, again, I want to thank you. That was a wonderful presentation, and we look forward to working with you again if we can.
Thank you very much.
All right. Okay, David?
So, I want to thank the Addison and Beverly team there. That was a great presentation. I think Commissioner spoke a lot to some of the themes and questions that you were talking about, both in terms of the qualitative but also the quantitative components to this, as well as what are some considerations that hospitals are thinking about as they move this forward. And as was mentioned before, we will be doing this systematically across the entire cohort of chart hospitals through our evaluation.
David, it would be a good idea in looking at this. I think it's great that they're going to continue the program, but they're also incurring close to $1 million in additional costs within a 9-month period of time. And the question becomes, are there other sources of revenue that's being generated to offset those losses for the hospital? We can clearly see the payers will benefit from the program, but it's important that the hospital be motivated as well, in addition to just providing the services, which you're trying to do. So to look at that other piece of it, I think it becomes important in terms of sustainability.
Absolutely, and we have heard anecdotally from a number of the chart hospitals, similar to Leahy, where some of these functionalities are moving from the hospital to the ACO. And as the Secretary mentioned before, most of the chart hospitals are participating in the Mass Health ACO program, although there are some in central and western Massachusetts who are not. And so that's another way that some hospitals are thinking about continuing these programs.
I was puzzled by that too. Are you participating in a Medicare ACO? And if so, are there savings to the ACO from that?
Thank you. Leahy will be participating in a Medicaid ACO, and there will be some savings attributable to that.
Medicare in this case.
Medicare. Yes, we are in a Medicare ACO also.
So shouldn't the ACO be realizing the savings from this?
Yes.
So have you done an accounting at the ACO level to see where those monies are?
We have not done an accounting at the ACO level specific to this population. No. It's a good suggestion, and we will go ahead and do that.
If money gets tight, I would call Ron and say, hey, Ron.
We will do that.
Say, hey Ron, we need to figure out the savings to the ACO here.
All right, well, we're a little bit short on time here, so I'm going to try to keep us moving quickly through the agenda here. And for our next agenda item, wanted to bring forward to the Commission for discussion and consideration are designed for our next round of investment, a $10 million grant opportunity. And this opportunity and design really builds off of our experience in CHART, as well as our experience in the Healthcare Innovation Investment Program, which is ongoing. By way of process background for the commissioners, we've been working on this design for the better part of a year and have been engaging and seeking input from a whole wide range of stakeholders, external expert, our CHART hospitals, ACOs, as well as a number of our sister agencies such as Mass Health, the Department of Public Health, and the eHealth Institute. We've presented this design a few times to commissioners now, including at the last board meeting, and at last week's committee meeting, we did go through this in some depth, and the committee did vote to endorse it, to move it forward to the full board for consideration and final approval. Importantly, this design builds off of multiple years of research and data analysis that indicates a significant opportunity to reduce costs, improve patient care, and promote a more efficient care delivery system in Massachusetts by focusing on reducing avoidable acute care utilization. This was certainly a theme that came up multiple times during our most recent cost trends hearings, and market participants in Massachusetts in our pre-file testimony indicated that reducing avoidable acute care utilization, specifically ED visits and readmissions, was their top priority in terms of how they wanted to seek to reduce healthcare costs moving forward. We also heard from Karen Joy-Maddox, who was an expert at the cost trends hearings, on the importance of accounting for and addressing health-related social needs in order to drive down avoidable utilization. Additionally, we heard presentations from panelists and from CHIA around patients with behavioral health conditions who are more likely to be readmitted to a hospital, more likely to board in an emergency department, and more likely to be revisited in an ED. All of these, we think, are indicators of a healthcare system that is failing to meet the needs of its patients in less acute and more community-based settings. Finally, I would note that as persistent as behavioral health integration and addressing health-related social needs was at the cost trends hearings, I would note there were some commissioners who, at the end of the hearing, I think expressed both disappointment and maybe some frustration that market participants were generally not implementing strong programs to address these known problems. And that really is the focus of this next round of investments, is to seed and support new models that truly get at these issues, build the evidence base, and that are sustainable and scalable for adoption by the broader healthcare system. So with that as background, I'm going to turn it over to our Director of Policy for Care Delivery, Katie Shea Barrett, just to walk through the highlights of the design we are presenting here today.
Great, thanks David. I'm going to go pretty quickly through the specifics since you've had a lot of context and a lot of pre-context through the past investment work about why we're focusing on acute care utilization. So $10 million, $750,000 per award. That's about $1 million project, because 25% has to be provided by the applying institution. We've amended the outcome slightly since the last presentation due to some feedback from our chairman, who always encourages us to put top of mind increasing the efficiency of the delivery system. And so we will be monitoring that throughout this program, but also looking at the key measures of admissions, readmissions, ED visits, revisits, patient experience, and for the track specific to increasing access to opioid use disorder treatment, engagement in medication-assisted treatment. In order to evaluate proposals, we're proposing 4 big domains that we also went through at the last board meeting, so I won't go through in detail here. But due to the great discussion we had at the last board meeting about the importance of engaging patients and families and frontline workforce in these projects, we have included that as a specific factor under the organizational leadership strategy and demonstrated financial need domain. Finally on the slide, we're proposing 18-month projects due to our lessons learned through the HCII program, including 3 months of prep to do things like hire staff, put in place care protocols, things like that, so you can really hit the ground running once performance starts on day 1. Any questions or comments? Okay, so we've talked at length about the high-level overview of what these tracks are. You know, there is emerging evidence that addressing health-related social needs by addressing social determinants of health and addressing behavioral health needs does impact acute care utilization. We want to continue to contribute to that evidence base through this program.
And so that's why we are proposing these two particular funding tracks. There is a sub-focus on opioid use disorder treatment, as we were required to allocate no more than $3 million from the Distress Hospital Trust Fund to do that. So eligibility, this probably seems like a more complicated slide than it actually is, but eligible entities for the first two tracks are any healthcare provider or provider organization in Massachusetts. Eligibility for the substance use disorder particular focus is any acute care hospital with an emergency department in it. More competitive applicants are ones that are part of an HPC certified ACO. We will, I in particular, will be very excited to share with you the news about our certification decisions at the end of next week. We've been working hard to process those applications, and they're participating providers or a chart eligible hospital. So prioritizing applications from those parties in line with our sustainability and scalability goals for this program. Similarly, for the opioid use disorder focus, ones that are hospitals that participate in an HPC certified ACO or are chart eligible will also be prioritized. Most importantly on this slide, you'll see that we do require community collaboration in every single track. Applicants that propose passing through money to those community partners will be more favorably reviewed by the Health Policy Commission. I think we don't need to make that case. You've heard from the team at Leahy and our staff about the importance of community partnerships in order to really make this work meaningful and to actually see results in reduced acute care utilization and improvements in quality. So we hope to have a vote today if you all like this design, and we will work hard to implement an RFR and release it just after the new year on January 8th. We already have scheduled an information session for anybody interested in getting more information. It will be a webinar. It will be recorded and posted on our website. That is January 11th at 2 p.m. We are hoping for responses back by March 2nd. I do know that that is the day after the Mass Health ACO program starts, and so that there is a lot going on in the world right now. But hopefully, that this time period before it starts is a better time period to ask for applications than once it starts. And then coming back to you in April with a recommendation for proposal step back.
Okay, we have a motion on page 76, which would approve moving forward on the project that Katie laid out. Is there any questions or comments? If not, is there a motion?
I'm actually quite worried about the timing of this. And who are so it's any mass healthcare provider or provider organizations eligible?
Yep.
Why would you not be focused on non-ACOs? So for the rest of the hospital and healthcare system that's not participating in the Mass Health ACO?
It's a fair question. I think the eligible entities are any Massachusetts provider or provider organization. So that could be a VH provider, an LTSS provider, any provider that operates in the Commonwealth. We have prioritized folks that participate in ACOs because they are receiving reform payment today. And that in order to have a really solid sustainability case, based on the prior discussion that we just had about the concerns of making the case for continuing investment in this program, if you're not operating in a reform payment environment, I think it's just going to be harder to make that sustainability case.
How will you ever be able to evaluate the outcomes of this limited amount of money versus the ACO requirements around evaluation?
It's a fair evaluation question we will have to figure out.
We have that as one of the criteria that the applicants will have to provide to us is an evaluation plan and strategy, and that will be part of our assessment of the different applications that we receive. And we are not foreclosing. We've heard again and again, sustainability is really important. We don't want to fund projects that are going to be ending in 18 months. And so that being said, we have allowed for all Massachusetts providers to apply, and that's consistent with what our statute lays out for these programs.
We, as a point of alignment, are expecting that a number of systems are probably going to put up their 25% from their district funds, and that potentially our funds would allow them to do something on an all-payer basis, whereas the district funds would be targeted on the Medicaid population.
In terms of your question about timing, what would you propose?
So, we've just signed all the contracts for all the behavioral health providers. The ACOs are in, I don't want to speak for ACOs, but I certainly get a lot of phone calls about the data, the metrics, the full course ahead for March 1st. We're not changing the date for March 1st. So, I mean, the same people who are implementing the ACOs are the same people who will be doing this. So I'm actually quite concerned about time.
So pushing out by X amount?
Well, you know, I know there's been back and forth with the Mass Health team and others. I have to say, in looking at this, I'm on a number of fronts I'm concerned. One is actually how can you possibly, these, we all want this to be successful and to bring down costs. So, and there's a lot of district money out there, which is not dissimilar to what I believe what some of the intent is of this funding as well. So I don't know how you could actually evaluate the effectiveness of this to organizations who are actually ACO district providers. That's one. So just the purity of evaluation, I'm not an academic researcher, so I would leave that to the other end of the table here. That's one I'm concerned about, but more, I guess I would also say, and maybe I should take this back, is for those who are ACOs, they have an advantage by putting up their share of the district dollars to match this. So what about the other hospitals who might actually want to be changing their systems, who aren't quite ready for the ACOs and the like, who don't have the district dollars to match up? I mean, it feels, just reading this at this moment, it feels like it's not exactly, in some ways, it's an unfair advantage. It feels to me, Stuart, like we're leaving those folks who are not, could not, can't be part of this ACO, Mass Health ACO, at further disadvantage to systems change, in some ways. That's all.
So one note on that particular point was we did want to have a similar prioritization and preference for chart eligible hospitals, and those may be charter hospitals who are not participating in the ACO. So those would continue as our cohort, and some of those who are, as you know, not participating in the Mass Health ACO program would continue to have preferential consideration of their awards.
So, I mean, I think this is an interesting subject that I don't know the answer to. But you can make two different arguments. One is the ACOs in general are up against a pretty tough set of headwinds against them in the bigger sense.
We like to think opportunities are approaching next year.
Well, but let's be fair. I'm not saying so much in Medicaid, but given the fact that there's pressure in Medicare, and so remember, there are two sides of the sword. So one says, you know, let's give them an advantage because they got enough disadvantage and let's see if it works. On the other hand, what you said is true. So I'm not, you know, you've raised this, I don't know the answer. Should we give them an advantage or should we just ignore it? I think it's a fair question.
Should we think about this until the next board meeting? There are a lot of issues here that have now been raised. I think we should step back because we do want this to succeed.
Is it just the competitive factor piece? Because we could do this without just taking that piece out.
I don't know the answer.
I actually would prefer if we could take this and end it from
So if we do that, let's take kind of follow on your and Stuart's questions. Let's make a list of the questions we want answered rather than just kicking the can down the road. So what do we want the staff to come back with answers? What questions do we want the staff to come back with answers to when we meet in January?
Was it asking ACOs if they perceive it to be too much work to get ready for the Mass Health ACO program and to submit an application for this program? Is that the most important question?
I think it's the competitive factors and the timing issues, if I'm hearing from the commissioner. So we can do that.
Okay, that sounds fair.
Yeah, I think the third question that Mary Lou asked, that's, we may not be able to answer in that time frame is kind of a more specific outline of what it is you're going to want the applicants to produce in the evaluation section, and your own best thinking using us as your experts about how we make sure that the evaluation of this program isn't confounded by the disrupt issues. And you know, we may or may not be able to answer that question. That's also something that shouldn't hold up our making a decision in January.
So we're gonna hold off on then.
We'll table the vote for today, and we'll come back
Good.
in January and spend a little bit more time on some of these details. Thank you, that's really good feedback.
No, it is, and, but overall, really impressed with what's been going on in a couple of years. Yeah, again, we want to understand, you know, where we're making definite improvements in the quality of care and in investments. We want to understand it and make it available. Thank you.
Great.
Okay, we need to move on. We are running a little late, so if we can tighten up the discussion, not that this isn't a very important project, but it's also an area that we have focused on. So.
All right, so I'm going to keep us moving while the cost trends team comes up here. And for the next part of the agenda, we're going to be presenting some select findings from the upcoming annual cost trends report. As is our past practice, what we do is we basically split up this presentation over 2 board meetings. And so in this board meeting, we're presenting some select findings for you that will be included in the cost trends report. We're very interested in your feedback and context and input and how we frame up some of these findings and where there might be continued areas of exploration. But we will be back in January at that time with the full report with input from all commissioners and policy recommendations at that time. So we're not doing policy recommendations today. We are not releasing the full report today. Today is really an opportunity to walk through some select findings. So really quickly, we showed this slide at the committee meeting. Just want to highlight that we are doing a revised approach to how we think about our research, reporting, and publications. And I think imitation is the sincerest form of flattery, and we are imitating some of our sister agencies who have really led the way in doing more data visualization, doing different types of more visual reports. I want to highlight the Chapter 55 report by the Department of Public Health, which pulled data from a number of different sources and put it on a website in a really engaging way with the audience. CHIA has also moved more towards kind of graphs and charts and away from kind of full written 100, 200 page reports. And so we are following that lead in terms of moving a little bit away from a huge textbook in terms of an annual report and findings that are more visually engaging and accessible on the internet through new interactive tools. So with that, I'm going to turn it over to our Director of Cost Trends and Research, Dr. David Auerbach, who will walk through some of our findings. And again, I encourage you to chime in and ask questions along the way.
Great. Thanks, David. Okay, and I'll try to see if we can save some time in this next section. So before I start, I want to acknowledge the hard work of the Research and Cost Trends team. We're all sitting back here, and you'll see some of their work reflected in this presentation today. Amazing work, and there's ongoing projects, as David said, that are not going to be in the cost trends report, but expect more publications, more types of publications coming out in the next year. So the report, the presentation today is structured into these 3 sections. We'll first present some overview of spending trends in the delivery system. Then we'll present some opportunities to improve quality and efficiency, and then some progress in aligning incentives, and a slide on the future outlook and where we think we might be going. Okay, so for the first section, let's start with performance against the benchmark in the last year. As we all know, Massachusetts healthcare spending per person grew 2.8% last year, between 2015 and 2016, that is, and that's below the benchmark rate of 3.6%. That bar is hashed because it's a preliminary number, but taking that for what it is, as David noted, the overall average spending per year over the 4 years is just under the benchmark at 3.55%. Very exciting.
Did the
Yeah.
national number just come out? Do I recall?
It did. It's coming right up. Thank you. So here we go. So now we're showing annual spending growth in Massachusetts in the orange compared to the national spending growth rate in the blue. And this is updated again just 2 days ago, that blue dot for 2016 in the national. That's right. So it did come down from its preliminary projection from CMS, but still Massachusetts is below that trend, just barely. But that gives us 7 years in a row of being below the national growth rate in healthcare spending per person.
Is that a preliminary number? Are we doing apples to apples here? Because the orange is.
Yeah.
preliminary.
That's right. The orange number is the preliminary 2.8% that I just showed. The blue is final. The blue is just as of 2 days ago. That is the US growth rate.
So this chart will change.
The blue won't change, but
I know the blue.
yes,
won't
the
change.
orange,
You said
the
it's
orange,
fine.
that's right. The orange will change.
I do
but-
understand the difference between final.
But the sources of error are also different, so they're not constructed in exactly the same way.
Although through 2014, they are apples to apples because we're using that CMS data.
So pre-2014, it is apples to apples.
Yep, because that's coming from the CMS state healthcare expenditure accounts, that's right.
And then it changes to that.
Then we switched to CHIA for the mass for 15 and 16.
And what's the US number in real numeric?
What is that data point there?
Yeah.
I think it's about 3.5. Does that sound right if the right person is here? Okay. I can get you exactly, but it's about there. Yeah. So then we can break down that 2.8% growth by market segment, and that's what we have here. And we're showing in the blue bars growth in spending per person in each of these market segments, and then the yellow is change in enrollment in these categories of care. So you see the commercial spending growth per person was 3.4% with relatively flat enrollment. In Mass Health, we're just showing the PCC and MCO program, and we'll note here that 5% per member growth is really reflects a worsening risk pool in those populations, partly from eligibility redeterminations. So the risk-adjusted growth there was really about 1.1%. There was some decline in enrollment there. And in Medicare, you see a different situation. You see very low growth, flat growth per person. That's reflecting what's happening in the national Medicare program. But we do see enrollment growth in Medicare. And this is something that we remarked last year. This is really coming from an aging population, and we can expect growth like this year after year. And it adds about 0.5% to our total spending trend each year.
How was Medicare defined?
This is, it's enrollment in Medicare fee-for-service we have there and Medicare Advantage. So it's just per the number of people that are enrolled. This is data from CMS. Is that what you meant? Yeah. So enrollment in Part A or B is in the fee-for-service numbers there. I'll get into Part D in a second, yeah. So Part D enrollment is not really reflected here in these, the spending it is, but not in the enrollment. Okay. So then we can look at the spending changes over the last 2 years by category of care. 2014 to 15 is in the dark color, 15 to 16 is in the light blue, and this is all payers now combined. So I want to highlight that in 2015 to 16, in the last year, hospital outpatient was one of the fastest growing segments, and also growth in the pharmacy area of 6%. And we are going to spend more time on the hospital outpatient a little bit later in this talk. The pharmacy, that is partly inflated by a big growth in Medicare Part D enrollment. We're not exactly sure why that happened, but a lot of people who had been just in A and B coverage only signed up for Part D in 2016, and that pushes that number higher.
Again, as you and I have talked about,
Yeah.
where it is not adjusted for per patient or per population, we need to somehow make clear, because there is a tendency, particularly when you just present slides, for people to say, well, I'm looking at it compared to 3.6.
That's right. I should say these are not per capita, but these are total spending changes. That's why it's higher than THCE. Okay. Now let's move to the commercial market only. Again, Massachusetts is in the orange, and we see over the last 4 years significantly lower growth in commercial spending compared to the national average. About 2 percentage points lower growth than the US. So we're highlighting the amount of total savings relative to a situation where if we had grown at that US rate in our commercial market, we would have spent $5.9 billion more than we did spend. So that's in the total commercial market, including employer coverage and individual coverage.
I think you ought to say that for the record, Stuart.
What is it?
Well, I was saying what's really interesting about this graph is the difference between 2006 up to 2012.
Yeah.
And then what happens after 2012. And he was remarking that 2010 was when we went crazy. So just for the finesse of it.
That should be correct.
That was an objective statement.
Sure. Okay. So now we're showing the trend in employer premiums. Okay. So we have family premiums in the blue, showing Massachusetts and the national average. Annual premiums for coverage, and single premiums in the orange and yellow. And I'll note that in 2012, our premiums, family premiums, were 11% higher than the US average, and by 2016, that gap has closed a bit, now it's 7%. So that's just reflecting the lower commercial growth that I showed in the previous slide. That's knocked off about 4 percentage points of our higher premiums. And the same story in the single coverage area.
And David, are you going to look at, in the final report, premiums for small group versus large group? Because we hear that all the time, that the small group premiums are, higher. And, yeah.
That's right. Well, we focused on that in last year's report, and we didn't do it exactly that way this time. I'll show you something about small group coverage, which is interesting. So it's in differentiating the premiums, you really have to know the risk of the populations, and it's hard to compare. So you need a really good detailed data to make a fair comparison of those premiums. So we might be able to say something about it, and we will try. But last year's report is also
Life is, clearly there's so many variables moving around here.
Yeah.
Massachusetts was known for having lower cost sharing than most other areas, but over the last couple of years, we've sort of caught up. So I'm just curious whether the top part of the chart is just the premiums or includes the cost sharing.
It is just the premium. It's just.
See, that's, you see what I'm
heading. We have looked at the cost sharing piece too, and
on the bottom you explain it, but so as I said, there are so many moving parts here. I don't know how you deal with it, but and I'd like to believe we are narrowing the gap, but maybe the reason why we're narrowing the gap is we're catching up to them in terms of deductibles and costs.
I think 1 or 2 years ago, we included the cost sharing in those trends, and even though our cost sharing is growing faster than our premium trend, it's such a small piece of the full spending that it won't change the story substantially.
Well, I think you should say that.
Yeah.
See, it's the reason.
We'll make sure.
As much as I support using graphs, if you just leave graphs alone, they can be as misleading as they are helpful. So to the extent that you need to explain to people, do it.
Okay. Great. Okay, so the final note on this slide is just
let people interpret them the way they want to.
Yeah. Okay. I know how that goes. So here we included a note on the cost sharing. So family premiums in Massachusetts in 2016 averaged about $19,000 a year. And including the cost sharing, we're up over $21,000 a year. It's really a tremendous number. So then I want to talk a little bit about the individual market in contrast to the employer market, where even though we have brought those premiums down somewhat in the employer market, this is showing single coverage in Massachusetts and the US in the top, and then below that, the coverage of the second lowest benchmark plan in the ACA exchanges in Massachusetts and nationwide in the lower series. And we are still the 4th highest cost state in terms of single premiums in the employer market. But meanwhile, our connector premiums are the 2nd lowest compared to all the other state exchanges. So that's really a remarkable difference. And you can see that levels of premiums are also different. So we talked a little bit about this in the past, but why is that? It's certainly a very competitive marketplace, and some researchers have noted that some of the techniques they use as an active purchaser, such as if you're below poverty, or you can only choose between one of the lowest cost plans, and that does drive the other plans to compete and be one of those lowest cost plans. And there are a number of other reasons that that might be, significantly lower premiums than the rest of the country so far. So that is also partly responsible for the lower commercial growth. Here I want to show a trend in enrollment, speaking to the small group market. We're showing between 2014 and 2016 changes in coverage by the size of your firm. And you can see most employer coverage is in very large firms. Those are what's called the jumbo groups. But as you get to the smaller and smaller firms, you see bigger and bigger drops in coverage, where you're talking about the smallest groups between 2 and 50 size firms. Coverage has dropped 8% since 2014. So this is an interesting trend to monitor as well, and people have thought about why that might be. But the employers, the offer rates are going down in that small group market too, and Chia has noted that. You see increases in coverage in the connector, and we can't track folks exactly, but there could be some shifting going on in those markets. Okay. And finally, I just want to note, I won't belabor this slide, but the lower commercial growth that we've had compared to the US, this has implications for real families every day. This is showing that we broke down the spending and the costs and said, well, how much money have we saved as a result of our lower commercial spending compared to the US, what it would have been if we grew at that US rate. And this suggests that the average family in Massachusetts in 2015 had $734 more to spend after paying for taxes and everything else because of that lower commercial growth, compared to what we would have had if we grew at the US rate. But you can also think about, well, what if we had kept those commercial growth rates even lower to the rate of inflation? They would have had another $500 to spend per year in 2015. Okay, so with that, I'll transition to a deeper dive on outpatient and prescription drugs with Sarah.
Thanks. Okay, as David mentioned, spending on prescription drugs in Massachusetts grew 6.1% in 2016 net of rebates, which was actually lower than the previous year of 7.2% growth in 2015 net of rebates. And I do want to highlight GIA's success in being able to track numbers net of rebates, which was a request that many have highlighted. In terms of what's happening next, in the future, projections expect mid-single-digit growth each year for the next 5 years. That estimate reflects increased spending from new products entering the market, as well as some moderating influence of increased competition, as well as greater scrutiny and negotiation on prices. Given the high levels of spending, prescription drugs has been an area of great attention across the country at the state level, including in Massachusetts, with proposals that would seek to increase transparency, as well as proposals that would increase competition, as well as a number of interesting innovations from various states. This is an area that we are continuing to watch. So we'll turn to additional opportunities that we've highlighted to improve quality and efficiency, starting with hospital outpatient department spending. This was the second highest area of growth in 2016 at 5.3%. Now, spending has a number of factors, as in all categories, but one very important dynamic that is particular to hospital outpatient spending is that is shifts in the setting of care. That includes shifts from inpatient to outpatient setting, which we typically think of as a high-value shift in care, typically lower prices, less intensive surgery, patients go home faster, as well as a shift from community settings to hospital outpatient. Community settings being physician's office, freestanding facility, and we've highlighted that as an area of low value shifts in care, because in these cases you're really talking about the exact same service but at a much higher price. And I'm going to show what some of those big difference in prices are and highlight that where those services are delivered really matters. Okay, so taking a step back and looking at where that spending, what that spending is composed of, the chart on the left is the categories of spending that make up hospital outpatient and their relative amounts per member per year. And on the right, we looked at how those categories contributed to the growth in hospital outpatient spending from 2013 to 2015, the most recent year of data that we have. So the categories that were the biggest areas of growth, or contributed the most to growth, were outpatient surgery. That includes both that shift from inpatient to outpatient, as well as some surgical procedures going in the other direction, and administered drugs. This is infusion drugs, this is chemotherapy, this is vaccinations, etc. I want to also highlight that even though places where the numbers aren't big might conceal big opportunities for action, and in particular radiology imaging that I will get to.
What falls under the all other services category?
That's a good question. So one thing that is important there is that would be where that would be sort of facility fees for, say, office visits. So everything else that doesn't fall into one of these other categories. But we have focused on sort of regular office visits that are occur in a hospital outpatient department, and that's where that would fall. Okay, so focusing on that, on surgery, we wanted to spend a minute looking at that shift from inpatient to outpatient. Here we looked at 5 high-volume procedures that are commonly done in both settings, such as hysterectomy, and looked at how that was changing over time. This is the volume for these procedures, and you see a pretty wholesale shift from about a 50-50 split inpatient, outpatient in 2011 to close to an 80-20 split in 2015.
Were we able to dig in and really find out what the costs are of moving from one to the other spending?
It's a good question, and we haven't looked at the sort of isolated what that is, but that's a good suggestion.
Because one of the things I've learned, sadly, is that we often think we're going to save all this money by doing this, and we find out that when you really look at the dollars flowing, it isn't as much of a savings as we thought it was. On the other hand, it may be a lot. I don't know.
To that point, Chair Altman, we looked at this, I think, in 2 cost trends reports ago, and did similarly find the shift from inpatient to outpatient. However, the total amount spent was relatively unchanged.
Well, that's what I mean.
And so
one walks away with this, oh, we must save a fortune.
So one hypothesis there is that even though volume may be moving out of the inpatient setting, there's also the element of price. And what is the price of those services that are still being provided in the inpatient setting? And are they accelerating at a rate to make up for the fact that volume may be shifting?
And can we split out those costs in terms of professional fees, facility fees, and other costs? Because that's such an important point when it comes down to price.
That's true, right? And I think that's it's a good suggestion to do to build on the previous work that David described and look at what the spending would have been had they stayed in the outpatient. Okay. So turning to that other direction of community to outpatient, wanted to give you a sense of the price differences that we're talking about for some common procedures. This is in the commercial setting, and you see a pretty substantial difference. Next, I wanted to turn to work that we did in the Medicare space. We undertook an analysis using Medicare data, both because the data is really great and also be able to do a comparison of Massachusetts to the United States. So I want to just take a few seconds and walk through the table at the top so that we're all on the same page about why the prices really are higher.
This table is for evaluation and management visits, regular doctor's office visits. That first column there is the payment in the community setting. You go to your doctor's office. They have a fee for professional services, and there's some overhead built in. The box on the right shows the total payment when that service occurs in a hospital outpatient department. You have a component that is the doctor's time, and you also have tacked on the overhead costs are broken out and tacked onto a very substantial facility fee that's attached. That facility fee is so high because it was intended to be the overhead for a service being done in a hospital and all the overhead that's necessary there. So the result of that you see is more than a double difference in price, from about $80 in the community side to $170 in the hospital outpatient department side. Also, that translates to the same double price difference or spending difference for beneficiary cost sharing as well. This isn't just the insurers on the hook, but the patients as well.
And this is what Medicare actually pays as opposed to what the facility has charged, correct?
Correct.
Right. It's about 10% of the charges, roughly.
And then we have additional services below, including two common imaging services. Okay, so turning from price to where are these services actually taking place, we focused on regular office visits here again, and
just so we're clear, we talked about yesterday, I would change you're going to change the title, and I would drop professional services and community, just have office rate, and then put a star there and says complete professional and others, because it's misleading to just call it professional service. Because you get this impression that, well, they get paid a lot more.
Okay, so here you see that in Massachusetts, routine office visits are occurring twice as often in hospital outpatient departments compared to the U.S. So the total bar is the number of visits per beneficiary. We're higher than the U.S. That's not a bad thing. But that blue component is the share of those visits that happen in the hospital outpatient department. And you see that we are double. We have 21% of our visits in Massachusetts compared to about 11% in the U.S., which is quite staggering.
Is that reflective of greater consolidation in Massachusetts than in other markets?
I think that could be, and that's certainly one theory of why patients are seeing their regular doctors, why that doctor's office is located in the hospital.
I think it's also what we've seen over time this past year, Marty, has been just the recalcitrance of shifting patients from academic medical centers out into community settings, less expensive care settings. And that, as I recall, and I don't have the data in front of me, that number just doesn't move. And we have been, to some degree, Mary Lou, let's take the $10 billion and just put it 100% in, could we please deliver community appropriate care in the community and not keep paying the academic medical center prices for routine OB. Now, that's an hypothesis, but I think that we've really seen the data over the past few years. Right, David?
Yes, and I would, we're going to show that slide again. We have another year of data that continues that trend. And I think another hypothesis in the national literature and something that we would want to dive into, and I want to avoid speculation here, but we do know that hospitals and health systems that are anchored by hospitals have increasingly been acquiring freestanding physician practices and incorporating them into their system. And when that happens, they can convert from a freestanding physician site into a hospital outpatient site. And we may have, Massachusetts may be experiencing that at a much greater degree than the US. So it may just be a matter of, these are the only sites of care that are left available. They'll also have to be twice as expensive.
So just so we're clear, the word community is used in two different settings. One is a community hospital, the other is a community setting. A community setting is not a community hospital. So just, and, but I don't disagree with anything you said. I think the issue, you know, if we compared the hospital outpatient and as you did in another case, and had, you know, academic and then community and then true community, you'd have three different rates.
Certainly that is, certainly I would expect that to be true on the commercial side. In the Medicare hospital outpatient side, you don't see in nearly any difference between even teaching and sort of non-teaching hospitals in Medicare rates on the outpatient side.
Sarah, have you done the calculation as to what would happen to the 5.5% hospital outpatient growth if the share of visits in physician offices had remained the same?
That's a good suggestion.
It would be interesting to know how far down.
That's a great point. But what we did look at is the spending impact of where those visits are occurring, adding up the difference in price and the difference in setting, as well as our higher visit rate. In general, you see that the cost per Medicare beneficiary for regular office visit rates is 25% higher. Now, if you, ignoring our higher visit rate, that's not necessarily a bad thing, just looking at our higher use of hospital outpatient departments for the same visits, we've estimated that excess spending totals about $56 million a year from those alone. We are not the only ones who care about this issue. This has been an area of increased attention in the Medicare program, as well as among commercial payers across the country who are starting to get interested and start experimenting with ideas such as site-neutral payment, and this is another area that we'll continue to look at. And then we'll turn this back over to David to talk about other opportunities that we've highlighted.
Great. Okay. Thanks, Sarah. Okay, now we have some utilization trends that we've been tracking over the years. This slide is showing trends in Massachusetts and the rest of New England and in the US in several types of visits, hospital outpatient visits on the top, which we've been talking about. And we are still, even though we've come down towards the US average, we still have about 50% more hospital outpatient visits than the US average. Part of that is due to what we just saw, those E&M visits. In terms of ER and inpatient, we are also closing the gap with the US, but we're about 10% higher by 2015. Now we can focus a little more on the inpatient hospital trend in Massachusetts. We divided this by age. And the point here is you can see that between 2011 and 2014, inpatient hospital use went down in Massachusetts by about 10%. And we noticed that last year it stabilized, it didn't keep going down. In 2016, the same thing. It's staying pretty much in the same place or ticked up by about 1%. We don't know exactly why this is, but we're looking more deeply at some of the conditions behind this. We've also tracked our ED trend over time, and you see the same overall trend on the top with the rate of ED use declined from 2011 to 2014, but it's been flat since 2014. And we've been dividing these ED visits by category or type of visit. And I'll just note on the bottom, we've tracked behavioral health related ED visits for a while. These have been going up, and they continue to go up in 2016. That's a total growth from 2011 to 2016 of about 22% in terms of the number of behavioral health related ED visits per person. So we wanted to focus even more on that trend And you can think about behavioral health-related ED visits into a few subcategories. Here we've divided those further by mental health-related, alcohol-related, and other substance use-related visits. In the latter two categories, the alcohol and the SUD have really grown and pushed this trend higher, more than the mental health, which has also gone up, but not as much. Okay, readmission rates, we've been talking about this. We know that the rates in Massachusetts have been going up despite the success of many of the CHART programs. This is the overall rate in the state. And even though in the US, it's been continuing to trend down, we have gone in the opposite direction since 2013. We're still waiting for 2016 data on this. So hopefully that will move back in the other direction, but so far the trend isn't in the right direction. In here, the trend we've been talking about with are community-appropriate hospitalizations happening in community hospitals. And the percent that are doing so has been declining gradually over the years. It declined a little bit more again in 2016. So you can see that 6-year trend just going in one direction. Okay, finally we have a positive utilization trend in the area of post-acute care. Another one of Wendy's favorites. So this chart is showing the percentage of hospital.
That it was positive. Yeah. I thought when you got to the end of the last slide, I thought, this is so depressing.
It is a little depressing.
Whoa.
Well, we saved it for the end. Okay, so here we're tracking the percent of hospitalizations that end up being discharged to either an institutional facility, such as a skilled nursing facility or home health, or a routine discharge to home. And the percent on the bottom that are discharged to an institution dropped between 2014 and 2016 from 20% to 19.3 to 18.7. So that is a significant drop. This is controlling for patient characteristics, controlling for condition. And when we look deeper as to the types of discharges where this is dropping, it's mostly in the musculoskeletal, the joint replacements, where they're figuring out how to have less of those go to a SNF.
David, just a question that may need some analysis. If you just took our major systems that have an academic hospital as part of it, but also had a number of community hospitals, and can you compare over these 5 years what's happened to the distribution of the patients? So if you took our 5 or so big systems, which has academic, partners in Israel and Leahy and maybe Stewart and stuff like that, and then looked at within their systems whether they have moved some of them out and they're doing in the right direction, or are they contributing to this number? I don't know the answer to that.
Okay.
But it clearly has an impact on when we worry about mergers and acquisitions.
Yeah.
So I think there's two analyses you're probably getting to. Sort of one is around the share of community appropriate discharges and where those shifts are happening, and are they going more to the AMC or to the community hospitals and these systems that have both included in them. And that's something that we looked at when we did some of our post-transaction reviews, which is where a community hospital was joining a larger system. Were they successful in actually redirecting care? And so that's something we can continue to work on. The second thing here is around discharge to skilled nursing facility, the post-acute care, and we'll actually see in the next two slides, we put it, actually identify individual organizations. And there is variation among organizations about whether they have been following the statewide trend.
So one of the arguments we get all the time is, well, we need to expand and pull in more community hospitals that allows us to send more of our patients out. I just want to see if it's true. And we do it in a not hit or miss. We do it when we focus in on a particular institution, we focus in on that, but it would be good to see this chart.
So in the interest of time, I'm going to just finish.
Can I ask one question?
Yeah.
Just on the institutional post-acute slide, have we looked at the impact of a discharge plan to home versus a SNF and its impact on readmissions to a hospital or ER visits?
Not in a statewide way, but a number of the CHART programs have talked about that. I would love to know the extent of discharge planning, at each hospital. I don't know if that data is really, then could link it to outcomes, but I'm not sure how well that's possible at this time, but it's a great suggestion.
And to just quickly run through these last two slides, and I think we can save some of this presentation for maybe our next meeting. But on the next slide, you can see here we looked at the rate of discharge to institutional PAC by the different hospitals. And we did adjust for patient characteristics here. And you can see that there continues to be a lot of variation among hospitals and where they're discharging patients to in terms of skilled nursing facility versus other sites of care. And then finally on this next slide, where we had seen some progress statewide in reducing discharges to skilled nursing facilities or institutional care, that was not consistent across all institutions. And so here we looked at the difference, the changes in their rates of discharge to institutional post-acute care. And you can see on the left-hand side of this chart, a number of institutions actually increased their rates of discharge to institutional post-acute care, while on the right-hand side of this slide, you can see a number of institutions were quite successful in making significant headway within a year. So I think, to your point, Commissioner Foley, one of the things we have used this type of research and reporting for before is to go and actually talk to some of these organizations and to say, to an organization perhaps like Lawrence General, it appears you've made some significant progress in this last year. What have you been doing that has allowed you to make that change? And then we will hear qualitatively, we've worked on discharge planning, we created a new relationship. I'm speculating, of course, here, but these are the types of things we can hear from the community around what is actually driving some of this differential performance. And then I think the last slide on this particular chapter, and then we'll close this part of the presentation, is an update that we have done, which looks at total medical expenses by patient, by provider organization over a period of time from 2012 to 2013. And you can see that Partners continues to be the highest total medical expenditure for these patients, and that continued into 2016. And the other organizations, there's some convergence over this period of time. Again, this is total medical expenditure, so this just looks at HMO patients that are attributed to these organizations, and this is CHIA's data that puts this together. What we're not going to walk through today, but I think we can probably save for a future board meeting, is an expansion of this work that we've done, which attributes not only HMO patients, but PPO patients to provider organizations, and looks at their total spending per members and utilization across a number of different areas. So I think we'll hold some of this for a future date for discussion. The committee did spend some time on this particular part of the presentation. So with that, I think we can skip to the end here, David. I'm going to jump all the way to slide 122. Which just highlights some of the key findings that we had selected here today.
Why don't we just move on? We're really late.
So I'm closing this off. So this is just a last slide with the key findings. I won't walk through it, and we can spend some more time on this later. So thank you.
Great. All right. More to come.
So for our next agenda item, we are going to move into our market oversight role here at the HPC, joined at the table by Kate Scarborough-Mills, who is our Director of Market Performance, and Megan Wolf, our Deputy Director. We're going to walk through our standard notices of material change, although I think given the time, we may just want to skip ahead to the main agenda item here, which is a discussion of a material change notice. I would just note for the Commissioner's edification, we do still have a CMIR in progress, which is the Mass Ioneer and Partners Cost and Market Impact Review. We did receive a response from the parties at the end of last month and are preparing that final report for your review and input, and hope to present that for your final consideration in January. So with that, I think we can move to the heart of the matter, and I'll turn it over to the team.
Great, thank you, David. We're going to skip over this. We've received 88 notices. 8 are still under review, all of which were received prior to our last meeting, so we've already had the opportunity to speak about them. We have 1 CMIR in progress. And most importantly, as I think all of you know, the purpose of our 30-day review is to identify those transactions anticipated to have a significant impact on healthcare costs and market functioning. Today, we want to talk to you about one of the most significant transactions that's occurred in Massachusetts, or that is proposed to occur in Massachusetts in a couple decades. So what I wanted to do is just kind of walk through the transaction, what's being proposed, the parties themselves, and our staff recommendation that the Commission authorize initiation of a cost and market impact review. So there are 2 main components of the proposed transaction. So as detailed on this slide, first, there is a corporate affiliation being proposed encompassing full economic and clinical integration between the Beth Israel Deaconess Medical Center, including its 4 owned hospitals, including the main academic medical center and those 3 community hospitals that you see listed on the left. The Leahy system, including its 3 major general acute care hospitals, and 3 hospitals that are currently independent, Anna Jake's, New England Baptist, and Mount Auburn Hospital. And I'll note the asterisk here at the bottom is actually quite important. Those 3 hospitals, although they are independent, they do have key connections to the Beth Israel system. Both Anna Jake's and New England Baptist contract through the Beth Israel Deaconess Care Organization, BIDCO, and New England Baptist and Mount Auburn are both part of Care Group along with Beth Israel, which is an entity that allows them to do joint purchasing and borrow money together, but has not involved clinical integration or payer contracting jointly.
Would you just clarify in all of the materials that were sent out, for Mount Auburn, it was always noted as it was the physician organization. So they're already part of Care Group, but that doesn't mean that they're a part of this master organization. Are they just thinking about bringing the physicians in, or the whole enchilada?
That's a perfect question and a great transition to this slide. So the way the notices were actually received is that because New England Baptist, Mount Auburn, and the Beth Israel system are all part of Care Group was actually the filing entity. So we didn't receive separate notices from either Mount Auburn or New England Baptist, although they are all joining together. We did receive a separate notice from McKipa, as listed here. They are not actually proposing to join the corporate entity, which is dubbed NUCO. Obviously, that's a placeholder name. They are proposing to become a contracting affiliate. So they would still operate independently, corporately, but they would contract through the NUCO system. And so that's actually the second key part of this transaction, is this contracting affiliation with McKipa. Also important to note, this corporate entity, NUCO, would own the contracting networks of these parties. So it would own BIDCO, it would own the Leahy Clinical Performance Network, it would own the Leahy Clinical Performance ACO, and we anticipate that the contracting affiliates of the BIDCO network that aren't being acquired as part of this would still be contracting through this network. So CHA, Lawrence General Hospital, Metro West Medical Center, even though they aren't proposing to join this new corporate system, we do anticipate that they would still be part of this contracting network. So the next few slides just give a little bit of background on each of these corporate members, recognizing that we are short on time and the fact that most of our commissioners, I would expect, are pretty familiar with these systems. I'll go through them very quickly, but please pause if you need me to go in any more detail on any of this. So as you know, Beth Israel is anchored by one of our major AMCs. It has 3 community hospitals as listed here, approximately 417 physicians. It contracts through BIDCO. And as you see on the next slide, and as we've discussed in some of our past CMIRs, BIDCO has really grown very substantially in recent years. So since 2013, the HPC has received notice of 7 different BIDCO contracting affiliations involving 6 different hospitals, 5 different physician groups. And it now contracts on behalf of 9 hospitals and more than 2,500 physicians. And of course, 2 of their contracting affiliates, New England Baptist and Anna Jakes, would be proposing to now be corporate members of a joint system with them. Which takes us to Anna Jakes. So Anna Jakes is proposing to join NUCO through its parent organization, which is Seacoast Regional Health System. Seacoast Regional Health System also includes a physician group, Seacoast Affiliated Group Practice, which is a 35-physician multi-specialty practice. Those physicians also contract through the BidCo network as they're part of Whittier IPA.
But they would not join.
They are actually proposing to join corporately. It's only McKipa that would be joining as a contracting affiliate.
Not necessarily now. Some discussion at some point on the difference between contracting through BidCo and being part of this complicated new system might be in order.
Absolutely, and I'll note that, obviously we are running through this pretty quickly today. Here, the discussion is just whether this warrants for further review.
I know that.
If the vote is to do so, I anticipate that we will be having many more conversations about this in the coming months, and certainly would hope to speak about that in great depth. The next proposed corporate entity is New England Baptist, which, as you know, we issued a CMIR on last year, so there's a great deal of information we've discussed with regard to them. Here they are a specialty orthopedic hospital in Boston with 3 outpatient clinics, as you see listed, as well as a little over 100 physicians. As with most of our specialty hospitals, they serve a wide geographic area, which you see on the map on the right. In total, BidCo's general acute care hospitals, so all of its hospitals except for New England Baptist, serve a wide swath of eastern Massachusetts. So in red here, you see owned BidMIC hospitals, both the AMC and its community hospitals. In orange, at the very northeast tip of Massachusetts, you see Anna Jakes service area, so they would now become a corporate member of this system. And the 2 yellow areas here are the Lawrence General Service Area and the Metro West Medical Service Area, which we anticipate would still be aligned through contracting arrangements, but would not be part of the corporate system. I'll note that CHA, which would also be aligned through contracting, their service area overlaps entirely with the BidMIC hospital, so you can't really see it separate from the red. The next proposed corporate member is the Leahy Health System. So that system obviously exists in northeastern Massachusetts, as you see on the map here, including about 1,000 physicians and 3 hospitals, including their medical center in Burlington, as well as Peabody campus, Northeast Hospital, which is composed of both Beverly Hospital and Madison Gilbert, as well as Bay Ridge Hospital, which provides psychiatric services, and Winchester Hospital. And the last major corporate affiliate being proposed is Mount Auburn Hospital, a 227-bed hospital in Cambridge, which currently contracts independently. You see its service area noted in the map. And McKipa, as I've noted before, is not planning to join the corporate system. It contracts independently on behalf of about 500 physicians, including the docs at Mount Auburn, as well as some other physicians in Cambridge. They would become contracting affiliates of this new system.
Would become a contract. Again.
So similar to the arrangement, for example, that Lawrence General has, where it contracts through BidCo.
Through BidCo, but it's
right.
Not in their.
But is not corporately aligned. McKipa would maintain a separate corporate existence, but would do its payer contracting through the NUCO system. So the parties state that their goal in the transaction is to create a new comprehensive and distributed high-value healthcare delivery system in Massachusetts, in eastern Massachusetts, with the highest quality of care and lower costs. You can see some of their specific claims detailed here. At its core, they claim that the transaction will create a system that will create a more competitive market in Massachusetts, will allow them to attract care away from their provider systems, to take greater risk for their patient population, to participate in innovative insurance products, expand needed services, and share best practices among the already high-quality providers joining the system. This slide summarizes the basis upon which we recommend that this transaction warrants a deeper dive and a cost and market impact review. So as I noted at the beginning of the presentation, this is really the largest proposed healthcare transaction in Massachusetts in decades. The combined entity here would have nearly equal the size and market share statewide of Partners' healthcare system. And just to give you a sense of that based on our preliminary analyses, Partners currently provides about 27% of the inpatient care across the state. The second largest provider network currently, Vidco, provides 14%, so a little bit over half. When you combine all of the entities that are proposing to be part of Vidco, that jumps up to 25%. And so we would be talking about Partners providing about 27% and the NewCo system providing about 25%. So really quite neck and neck statewide. And that is true across all of the different sections of services that we looked at, inpatient, outpatient, physician services. And when you actually cut it by specific regions, there are certainly regions around some of these proposed NewCo hospitals that would have much higher market shares for the NewCo system than for Partners. That increased market share brings with it the risk that NewCo would have more leverage with payers to raise its prices. And we might also see changes in utilization and referral patterns to redirect care to the NewCo system from other provider organizations, both higher and lower priced ones. As I mentioned, though, the parties claim that their growth would actually improve market competition, put price pressure on the highest priced competitors in the market, and that they would attract patients away from those higher priced competitors while improving quality and care delivery. Our recommendation for a cost and market impact review is that we believe that it will allow us the opportunity to examine all of these dynamics together to better understand all of these impacts on healthcare costs and market functioning, quality, and access. So I went through that incredibly quickly. I'm going to pause here for questions both on the parties and the transaction, as well as if there are particular things that commissioners think, if we were to conduct a review, they think that we should be focusing on. Just as a reminder, these are the factors laid out in our statute, although I'll note that the factor G here is other factors that we may identify. So here in particular, would love your feedback on factors that you would like to see us examine.
Just as a quick clarification, because this is so much more complicated than anything else we reviewed, would you, as you go through this preliminary report, make sure that we clearly understand what does it mean to be an entity going into NewCo? What does it mean to be a corporate affiliate of NewCo? And what does it mean to be a contracting affiliate of NewCo? And what pros and cons, what are kind of the benefits to the Commonwealth, what are the benefits to them for each of those different entities? Because I don't think we all have a common understanding of what Bidco means by each of those relationships.
You know, David, if you're not planning this, I would suggest you should plan it, which is not wait until the complete cost and market review is completed before we have the next discussion about this, that we set aside a significant portion of future meetings to go through the question that Wendy asked and 10 others that I have. But I won't ask them now, but you know, this is a very complicated, very important, and those numbers are really impressive in terms of how it would really change the structure of the marketplace in healthcare in Massachusetts.
I want to pick up on a couple of those themes. So we're obviously going to do a CMIR here because it's just too important to the Commonwealth not.
We might want to take a vote.
Yeah. We will take a vote, but I would presume that that's where we will wind up. Just a couple of observations to make about it. One is, as we've done other CMIRs in the past, we've found that when we have asked for information, projections from the parties about what will be the impact on admissions to various places and so on, we have not been satisfied with the answers that we've received from them, just as a general rule. We should convey extremely strongly to the parties that we really need answers to these questions. Because as you said, there are effects that go in different directions, some of which would tend to increase spending and some of which would tend to lower spending. And if they can't put forward anything substantive that says that it will lower spending, everything that's left will be that it will increase spending. And I don't want to be in that situation where we are saying to ourselves, oh, well, there is an argument they could have made, but they didn't make it, and so therefore we're just going to ignore that. That's not fair to anyone in the Commonwealth to do that. So if we really push them, I think that at the beginning, that would be good. The second point is just for my fellow commissioners, which is that in addition to this being the biggest issue we've seen in terms of material changes, this is also conceptually the most difficult of the material changes that we've had, because the economics tends to be much clearer when it's, say, a single large institution doing something as opposed to when it's, say, a number 2 or a number 3 system starting to do something, which means that our analysis is necessarily going to have more caveats than it typically does, and your aspirin consumption is likely to be higher than it typically is in these circumstances, just because it's just inherently a more complicated case.
I have just one question too, and not to give the answer today, but to think about, you mentioned in your remarks that the parties say that one of the things they'll do is they'll attract care, higher cost care, right, to lower cost settings. But then you put out there as another possibility, which is some of that lower cost care will be directed to the highest cost. So how are you gonna measure that? How are you gonna answer those questions before this happens and we know where people go?
Great, well, that's actually a fantastic segue to our next slide. I don't want to cut off conversation if there are other commissioners that want to talk about the factors we should be looking at, but to conduct our review, as you know, we have the ability to receive confidential data and documents, not only from the parties, but also from other market participants. So we have been fortunate that the entire market has really played an incredibly helpful role to us in doing our work in the past. Payers have provided a lot of key data. Certainly those entities proposing changes have provided key data, and other competing providers have often provided data as well. We are able to pair that with data available from a number of public sources, and then we work with a large team of expert consultants. So we work with several teams of economists, actuaries, accountants, care delivery experts, quality experts, and of course our expert group of commissioners. I would anticipate that this will involve a lot of interaction, certainly with our commissioners as well as our expert consulting teams. I'll also note that this transaction is under review by several other entities at the same time, and we are hoping to work very collaboratively with our sister agencies. So this is subject to a determination of need. This is being reviewed by the Attorney General. This is also under review by the Federal Trade Commission. And so there is another level of procedural complexity to this, just to flag for you as well. So that is kind of a high level of how we would do our review. As noted here, we do have the ability to receive confidential data, and so that is actually really core to us being able to do our work, is that we can receive data that is granular enough that we can really do some pretty advanced modeling. I think all of you are familiar with the output, so I won't go over it, except to say that obviously we issue a preliminary report, the parties have the opportunity to respond, then we have the opportunity to issue a final report and can refer our findings to other state agencies.
So within the last 6 months, there's been a significant number of studies done around the country showing just what impact consolidation does on prices. I hope we bring that research into the thing, because for the most part in the past, we've sort of just pointed to it without giving any dollar figures, but you could begin to use modeling that talk about what impact the consolidation has had in different parts of the country. And we don't know if the same would happen here, but you could just play out what the implications are as a hypothetical. That's, it's just, it's not, this is happening in other parts of the country.
I think that's absolutely right, Chair Altman. We're going to tap into the national experts and all of the latest and best research as we conduct this. And Commissioner Ward, to your question, one of you commissioners have highlighted the extreme complexity of this proposed transaction with multiple different entities joining or changing their relationships with NewCo. One of the, I think, advantages that we do have, however, is that these entities have been before us for review for many of these past transactions. And so one of the things that we will be looking at and examining is where there were claims made in the past around abilities to redirect patient care to more appropriate community-based settings. Were these parties successful in some of these past transactions where we have data and experience? And that may give us a perspective or some insights into whether we think it is likely that they'll be able to be successful in the future. So one advantage we do have is a pretty deep knowledge of most of these organizations. Obviously some of them, like Anna Jakes, Mount Auburn, and McKaipa, have not been before us for a review before.
Okay, so right before, all right, so where are you now?
Great,
Yeah,
so this is just a reminder of the timeline. It takes about 6 months, and then we are on to a vote unless there are any other questions.
Just to build off, before we take the vote, which I support we should move forward with, just to add, it was mentioned before about the complexity of this and needing to bring this back to this board or to the subcommittee through a continual basis. I want to second that. I think it's really important that through this complicated process that there's regular check-ins and conversations about it, and again, either at the committee level or at the full board level to fully understand, because the questions are many, and I know the timeline is short considering the size and scale and scope of this, so I just think that's an important point.
Good, thank you. Okay, I just want to make sure everyone's comfortable before we take the vote. Okay. Okay, so on page 145, we have the motion to authorize the cost of if someone put that forward? Okay. All in favor? Aye. Any opposed? Abstentions? Well, I know you've been looking at this for a little while, but you have a lot of work in front of you. And again, as we've said before, we need to really dig into it. There are lots of questions for us too. Okay, so now I need to bring before the group, we had a really great meeting, and we did go over in a number of cases, but the good news was that every presentation was important, and rightly so. And so here's the question I put for you. Currently on the agenda is a 40-minute or so discussion on our PIP activities and the information that we have that is not public that we could discuss. We are not under any obligation to do it today. We are, because of the need to make a decision with respect to the Mass Ioneer Partners, we are going to be having a full board meeting on the first week in January. Well, we're not sure. So so the question is whether we have this discussion today or we link that into that meeting, which would have been much shorter. And again, I can go either way, but is there any objection to moving it to the first week in January? David, do you have any problems with that?
Absolutely not.
It's Wednesday, January 3rd at 11.
Okay, is that now firm? Well, okay. Oh no, there's some confusion.
So, okay, very good. Well, so if not, we will table this part of the discussion. Again, I want to thank the staff. It was really incredible for all of you and all the presentations. So unless I hear any objection, do I have a motion to adjourn? All right. So move.
Happy holidays.
Okay, great. Yes, happy holidays.